He is the voice of all the postgraduate students in the college. Dr. M.S. Sidhu graduated from Dr. R. Ahmed Dental College and Hospitals, Calcutta University. He taught in Calcutta University in 3 of the 4 university examinations and won honors and gold medal in all the 4 professional years. He did his post-graduation in orthodontics from the prestigious All India Medical Institute, New Delhi, and was awarded the convicted Sri Mohan Lal Vic Gold Medal for the best clinical research work at AIDS. I welcome you, sir. We welcome Dr. Harish Yadav, the Research and Development Authority of SGT University. He is an eminent prosthodontist and has an experience of 16 years dedicated to quality dental health and academic excellence. We welcome you, sir. Now we would like to give a token of welcome to Dr. Burgess Mani. Sir, please kindly stand for the token of welcome. Dr. Yogra. Dr. Daya Shankar. Dr. M.S. Dr. Harish Yadav.
We would also like to kindly welcome our key speakers at today's symposium with a token of bouquet, Dr. David P. George, Dr. Akshay Shetty, Dr. Rakshi. Kindly give a big round of applause. Dr. Manikandan, and Dr. Ashish Shah.
HODs and professors, Dr. Ritu Dugal, Professor of
सरस्वती महाभद्रा Dean of Research and Development, Dr. Rajesh Yadav, other dignitaries of the dais, and my dear colleagues and friends. On behalf of SGT University, I extend a warm welcome to this first phase orthognathic symposium in this part of India. I think it's time to share how all this happened. I just met in 1 year back. Just we had one official inauguration on ceremony of Delhi University Chapter. So we had Dr. Kishore Naik as chief guest over there. And I think we should be proud that he is the first Indian to be the president for the International Association of Women Medical Research. He just gave the idea of why don't we start this space program, which has never happened here before. So the idea got instructed in my mind when I consulted the Varghese Panic of the panel of the wholeheartedly supported the idea. We was very happy to be part of the program. And again, when I discussed this idea with our PG director, Dr. MS Sidhu, he joined hands with us. Today we are here as a joint venture from both the specialties. Due to some personal reason, I think that Kishore Naik is not here with us today. Many excuses for the same. And Dr. Gurushenu is the next pattern of the program. He is joining us shortly. As always know, the proper treatment planning and good two-way communication between both the specialties and the patient's expectations are most important in getting the successful results in this field. For this reason, we have included speakers from both the specialties. One of the most rewarding aspects of orthognathic surgery is people centricity. Facial balance and harmony is the key to success with the additional collaboration and cooperation between the surgeon and the orthodontist, which can be facilitated through interdisciplinary approach. During this entire program, equal priority is given to both the specialty topics so that every delegate assembled here should get a message that the best results are possible. Only if you look at the skeletal deformity from both the orthodontic and surgical point of view. Fortunately, we have among us the best faculty here today. Each one of them are here not to share just their theory knowledge. They are here to share their vast clinical experience. I think already you have seen the sample of it today morning. The work speaks more than that. Just to give a brief introduction about the faculty of the day, we have Professor Dr. Varghese, who is the pioneer of orthognathic surgeries in India, who gave a new definition and broadened the spectrum of this surgery. 3 decades back, it was thought orthognathic surgery is one of the complex surgeries. So those are the days where most of the maximization surgeons were confined to oral surgery, nothing more than that. But it was always thought that orthognathic surgery is the most complex surgery. But when the Varghese proved to the whole world that with the basic facilities, with the basic setup and the basic automotive, we can get the best results. And he showed the whole world that what is possible. So I think today in the southern part of India, it is just like any other surgery is happening. It's become so common, so readily they do. And even today, like Varghese is quite popular for doing these orthognathic surgeries with the basic setup and the basic automotive. And the real credit goes to it. And I think we want to duplicate the same thing in this part of India. That's all. That should be better. Yes, other
I would like to call upon Dr. MS Sidhu for his comments.
Respected Dr. P. Toga, Vice Chancellor of SGT University, respected Dr. Mani, we have luminaries in the field of orthodontics and surgery together in this platform. I welcome you all to this august gathering, the heads of the departments, the professors, the faculty members, and my dear postgrad students, and many of the interns. This is a gathering of learning where we are trying to integrate for the benefit of the patient the two specialties together so that the concepts can be understood. When Dr. Dayashankar approached me in October October, November regarding this program, I was the happiest person because Dr. Vedas says we all think no end of our specialties only. The moment we start thinking of the patient as a whole, then we start combining, then we start sitting together, then we form a team. Till a team is formed, you cannot impart a fine treatment to the patient. So this skeletal malfusion, the craniofacial deformity, requires the effort of large, skillful people, and unfortunately North India was never exposed, including me. Through our training, we were never exposed to this type of integrated training. So this is a small effort in this regard, and I am highly grateful to the team of speakers who have come all the way, and I feel all of us must benefit, must take their advice, must benefit in all aspects, how and when we can impart these small points which we gather today for the benefit of our patients. Thank you, Dr.
Good afternoon, everybody. Respected Vice Chancellor Dr. Loka, Dr. Wiesman, and all the dignitaries on the dais, off the dais, HODs, faculty members, and faculty students. And sometimes students come to us for guidance, what subject to join in post-graduation, specialty. Then, there are different concerns and students' own taste, what is the financial prospects of the profession, and other things. And there are some pluses and minuses with all these specialties. Something which I thought was a minus with oral surgery was that the plastic surgeons were eating into the job of oral surgeons. In India, presently, we do not have the concept of exclusive oral surgeons being employed into trauma center. The patient, when he gets an injury, he is never coming to dentist. He is always going to a hospital. And in my personal observation over so many years, then the majority part of the dental part of the trauma is also included by plastic surgeons. So, since morning and I was there for Dr. David's lecture, and it gave me this great feeling today that this was the answer. This was just a few minutes back of the day I was speaking to him. He told me further that orthognathic surgery is the field in which even plastic surgeons are trying to drill, they are not very confident. And this is really good news for our profession. This profession which is being encroached upon by plastic surgeons and the specialty not getting its due. So I personally feel that this is a great field, great news that dental surgeons are doing well and exclusively developing this specialty in the country. Also, I will take this opportunity to tell all postgraduates sitting in this hall today that
Upon Dr. who is the mastermind behind the FACE Symposium and is a treasure house of surgical skills and wealthy experience. We welcome you, sir, for a welcome address.
Respected Dr. Dr. Sidhu, Dr. Yadav, Dr. Yash, my dear colleagues, friends, students, ladies and gentlemen. About 2 weeks back, I've been attending a conference in Nairobi. There's a Pan-African conference. That time there was a maxillofacial consultant, maxillofacial surgeon from the UK. We were just discussing, and then he told me that naturally, you know, in UK to become a consultant, you have to have a double degree qualification. There are two streams of people, one coming from the medical side and the other coming from the general side. So he says that, you know, those people who are coming from the medical stream, that after their MBBS they take a entrance to BDS or something like that, and then become maxillofacial surgeons. The other, after doing their BDS, they do their MBBS, and that's the two streams. Says that, you know, those people who are coming to the medical field, medical stream, they cannot even do an infection. Most of the time they mess up things. Even an orthognathic surgeon also they mess up. That is what he told me. I don't know how true it is. The reason what he told me is that, you know, they don't have a proper concept of occlusion. Occlusion is probably one of the most important things that we need for function. And of course, aesthetics is there. And aesthetics is the relationship between the jaws, between the upper jaw, lower jaw, and the whole of the face. It is basically not a linear measurement, it is a proportion that is more important. So now the question is, who is the custodians of beauty? Who are the custodians of beauty? Definitely I would say that somebody, custodians of the beauty in the face, not in their body, I would say. Of course, that is also important. I'm not saying that it's function. But when we consider the beauty of the face, the most important thing is a function. And for that, you should know properly what is function. After the medical side and the plastic side they come, they will not be able to do it properly. I fully agree that they probably, they are trained, they are good, maybe as good as us, or even probably better in soft tissue work. But when it comes to the body, the bone, that is the structural framework of the face, then we the maxillofacial surgeons, along with the orthodontists, can do wonders in face. We can really sculpt our face. It is a teamwork. And you know the definition of team. That is together, everyone achieves more. And this day's workshop, for the first time in North India, and I am actually grateful as well as congratulate from their center for organizing it. He has recorded me several times. And of course, they said that let it be there. And orthognathic surgery, and as they said that it is, well, I understand right now, it is not very popular here, but with this, I think that it is going to be very popular. And it is something which is not a very big need in orthognathic surgery. If somebody can do hepatic surgery, cancer surgery, orthognathic surgery, I think that for those people, if they know the proper technique, that's great. So, all the best to the conference, and I hope that we get successful.
Thank you, sir. We are really blessed to have your esteemed presence in the Face Symposium 2014 delegates here. Now, I would like to call upon our chief guest, Dr. T.V. Dogra, to please give a welcome address to the gathering. He is the pioneer in forensic medicine in India and he has solved the enigma of various well-known medical legal cases. We welcome you, sir.
I'm highly pleased to welcome you all to this workshop. The Faculty of Dental Sciences is one of the important constituents of the test, which has recently completed its course. And this university gives and for a collaborative approach in research and in practice. I have been a admirer of the dental college from a very young child, because this is a faculty which works in tandem. They are an excellent example of collaborative work without any complaints, which I have expressed earlier also. Dr. Yadav was the principal a month back or so, and he was promoted to lead the research and development of the university, and Dr. Deshankar took this position. Immediately after taking charge of the principal, he came to my room and told me that he is holding, came with an invitation that he is holding a symposium under the guidance of the pioneer expert for his money on 27th to 29th March on Bachelor of Facial Deformities, their production and outlet. My concept of dental surgery was different. Dental sciences were different. I was not aware of this aspect. So probably I got bewildered and I looked at it. Went back and came with some photographs. And he said that these are the patients whom I have treated, though they are in black and white, so you won't be able to appreciate eyesight. But when I looked at these photographs, I was really impressed. I asked this, you have done this? Yes, we have done this. Apart from that, many other works in very found earlier regarding all cases and all that. And he also explained that program which he talked about just now, that we will be getting financial assistance from some NGO, outside NGO, and we wanted to apply for that. I was really very happy with all these things and his work. I appreciate again that this collaborative approach, then he told me that all the associates on this kind of surgeries. I tell you the kind of programs he showed me, the kind of work he has done, it was excellent. I have seen few patients of cleft myself, where my evaluation was not good. The results was not so good. And then he convinced me, as Dr. Varghese told me, that the dental surgeons are the best surgeons to carry out this job of evaluation committees, because they know better about the practice. The dental surgeon may correct the defect, but he cannot take proper care of the practice, which is very, very important. He can professionally 100%. That part is well known to the dental surgeons. They are there of the people that are dealing with the evaluation and all that. So we are the better person to appreciate and correct it. Now, after hearing Dr. Varghese and him, I am very much convinced that yes, this is the right form. Right forum. And this forum is also very debate. To call it as a face. And I am extremely happy that its founder, Dr. Varghese, is with us. And there are about 120 participants from different parts of North India. We will undergo his lectures and live operations shall also be shown to the record by Dr. Now, this kind of with all that, I am expecting much more from the Faculty of Dental Sciences for this university to take this university's name to the height, and I am sure that the esteemed faculty, the officers of the faculty who are sitting on the dais, they will help us to fulfill our desires of making this university the best. Thank you very much. And also I thank all the faculty here who are really who are spending the precious 3 days of time with us. And especially I am very much thankful to the platform for work is money. Without whose support, this program would not have been possible. And thank you one and all.
I guess most of the crowd here is postgraduates. So I guess I will cater to the needs of the postgraduate. Nevertheless, this is kind of a bizarre topic that Rajshekar gave to me on soft tissue considerations in orthognathic surgery. I was wondering as to what exactly I would talk on soft tissues pertaining to orthognathic. In fact, I have a couple of my class students here, Amit, Arun and Rajshekar and Suni are here. And I've always said that although you do skeletal surgery to bring about changes in the face, it's my feeling that one needs to look essentially at the soft tissues more than the hard tissues, although you bring in changes in the patient's skeleton to affect the soft tissue change. So basically the face is a soft tissue mask that overlies the patient's skeleton. And the changes that you bring about, of course, bring about changes in the occlusion. Nevertheless, the effects of those changes are manifested in changes in the facial mask, the way one looks. So I always had a debate with most of my friends and orthodontists and teachers that evaluation of the face, I guess, should be more based on an external appearance of the face, much more than looking at numbers, because I don't walk around with a label on my face with the supplementary values. Although you need to look at supplementary values in terms of, clinical planning and looking at relapses and things like that. But I think supplementarics per se should not dictate the ultimate surgical plan, because you're not correcting numbers, you're correcting faces. So I said, let me see if I can put my thoughts across to you and say that look at faces in terms of your dimensions, your profiles, and how the soft tissues are, the competency and things like that. Then you come up with a surgical treatment plan based on what you want to do with this particular face. So for those youngsters here, orthognathic surgery, what is orthognathic surgery? Orthognathic refers to surgery of the jaws. Now when I say jaws, it's something to do with the upper and lower jaw. And when do you do orthognathic surgery? You do orthognathic surgery when in situations where there is an inherent deformity of the dental-facial complex. You might do orthognathic surgery in situations where you have post-traumatic deformities. You may have to effect a change in a post-traumatic deformity, and you may extrapolate your orthognathic skills to post-traumatic situations. How? Yes, the technicalities of doing an orthognathic procedure. Well, I'm not going into the details of how and the technicalities of doing the procedure. And so what do you understand by soft tissue considerations? I've just put some random pictures, bizarre, nothing specific, but nevertheless, you look at the face and see what the problems are. And as a person studying from dentistry, you might look at a class 3 be class 2 and class 1 and blah, blah, blah. Nevertheless, you look at what the problem is. Class 1, 2 and 3 relationships might be just enough. But here are the reasons why. Nevertheless, you look at where the problem lies. And look at all the soft tissues of the face, all the way from the hairline down to the chin into the neck as well. So, an assessment of an orthognathic case, one must look at, I guess, primarily the soft tissues and see how one could alter these soft tissues, the posture of the soft tissues, by altering the facial skeleton. And if you look at these cases carefully, I think I'll try and come into some specifics later on. But then, looking at the soft tissues, look at the nose, look at the cheeks, look at the lips, the posture, the height of the face, so on and so forth. So, let's try and see what are the soft tissues that one needs to consider. I mean, there are something called soft tissue analysis and things like that. I think I'll go into those a little bit later. But essentially, I think you don't need great values to assess the face. I think if you even bring out a street urchin, would tell whether this face is good looking or not. And he probably would point out, because when there is dysmorphism of the face, automatically the eye looks at the dysmorphic feature of the face first. So, when you look at this face, look at all these issues in the profile and the conformal projection. Look at the soft tissue of the chin. Sometimes, you have a face like this. This is a soft tissue chin which is quite redundant, and if you look at the vein graph, you realize that the chin is far behind, much more than what you see in this picture. So look at the chin. It might give you a false indication of prognathism or retrognathism. So look at it very carefully. Look at the thickness of the soft tissues of the face, on the cheeks, on the bony projections, the malar projections, on the nose. Look at all the soft tissues of the face, starting from, as I said, from the inferior aspect to the superior or whatever. Look at this. Look at his profile. And you will discover that this guy, if you look at him in the profile, he's got essentially, I've just put this picture for ventilating the surface, but nevertheless, you look at other areas as well. It's such a deep mental area surface, but there is protruding a point of chin. You can see that the mandible is too far behind. So essentially, the lower third of the face is actually back again. It's far behind. So you look at this, nasally, is actually a cleft lip alone. However, you will see that this area of the face is literally compressed. And look at his forehead. It's a huge forehead. So you want to balance that face, and you know the rule of thirds and fifths and whatnot. I'm not putting those pictures. But then you look at that. The forehead is so wide that this part looks so compressed. He's got a huge nose as well. And look at the posture of his lips. Look at his nasolabial angle. So what this guy essentially needs is opening up the lower third of the face to increase the facial height in the lower third from this point to this point. There is a double chin effect. There is a retrusion of the entire maxillomandibular complex. And what he needs, according to me, is increase in height here and increase in the sagittal direction as well. Of course, a correction of the nasal droop and a huge nose, and also a correction of the submental areas. Look at this submental area. She has an increase in the lower third of the face that you see. I don't think you need a great measurement to know this. Look at it just clinically. Look at the submental area. Look at this contour. I don't think anyone would like this contour of the chin and neck. Am I right? You would want a pointed, nice protruding chin good jawline, and I don't think any girl is happy with a double chin effect like this, an interlabial gap like that, and posture of the mouth, which is nothing interesting. So you're looking at all these areas. So you're looking at the submental area in this particular picture. Look at the lower lip. This is an apparent, what you call, class 3 situation. But look at the contour of the labiomental surface and look at the redundancy of the lower lip. Decide how you're going to correct it, because this redundancy is probably because of a profanation of the lower teeth or an over projection of the chin, which makes this a little more deeper, and the redundancy probably is because of the profanation of teeth. Look at his nasolabial angle and see how you would correct it. Look at his perinasal and malar areas, they're relatively flat. Just because it appears like a class 3, don't think that you can just think about either doing a maxillary advancement or a mandibular setback. Think how you can, because I don't think the rule is to go by the book. The rule here is how you can make him look better. And how you do it is left to the ingenuity of the surgeon. I'll show the picture of this guy probably a little later if I have. Look at this girl, apparent class 3 again, but look at the upper lip. It's what we call in British jargon a stiff upper lip. It's a very narrow lip, it doesn't give you the looks. No girl likes a thin upper lip because it gives you that wicked look, like the spokesperson of one of the BJP leaders, but I don't want to mention his names. Nevertheless, this is, it gives you a stiff upper lip and gives you a wicked look. So you're looking at an upper lip. This is a profile picture with apparently a truncated profile, a class 3 profile, or whatever you call it. Look at the nervous nasolabial angle. Look at the height of the lip. It's barely 5 millimeters in terms of that subnasal to whatever that lateral superior is, whatever you call it. But then it's a very short upper lip. You need to decide what you want to do for this case based on the soft tissues. Because if you think about doing maxillary advancement or mandibular setback, in a situation where it is a reverse bite, you can think about doing either a mandibular setback or a maxillary advancement, or you can combine the two. If the reverse budget is beyond a point like 10 millimeters, then you can't restrict to a single jaw. You have to decide on how much for which case. I would say, when I say that, how much for which jaw. So probably you can do a 50-50 advancement setback, 60-40 advancement setback, the other way around, and things like that. Then you need to decide based on the soft tissues. If in a situation like this you have a submental fat, taking the mandible back might make it a little worse. If in a situation like this you have a thin upper lip, you might end up producing a dummy smile if you do an advancement or an excessive show, in which case you may have to decide to do a maxillary intrusion as well. So the planning essentially goes not by the numbers. The maxilla might be apparently orthognathic or whatever you call it in terms of the numbers and the position and things like that. Then, if it is orthognathic, if the mandible is orthognathic, you decide to bring the maxilla forward, we need to think about this lip as well. The same picture of the earlier chap. Look at these perinasal malar areas. Look at them very carefully and see what you can do about those. He is an apparent class 3. I think I mentioned about this earlier. Nasolabial angle. This is one of my old patients. This is a result of a mandibular advancement already. Look at this nose. That's a huge parotid deformity. I think if you have to make her look better, there are several things that I think have not been addressed here. Number one, I think the mandibular advancement alone was not adequate. Looking at it retrospectively, this is one of our old cases, Amit is aware of it. I feel this was an orthodontic planning to bring the mandible forward alone because she was a class 2. We were looking at only class 1, 2, and 3 visits. In my opinion, I can show you probably some cases. Nevertheless, you can see that nasolabial angle is so obtuse. She actually needs what we call maxillomandibular advancement rotation, is what we call today. So, she needs a little more projection of the lower third of the face in the sagittal direction. So, she needs maxillomandibular advancement much more than the mandible alone, because the mandible that was brought forward here was just about 5 millimeters, and another 5 would mean that we have to take the maxilla forward by another 5 to match the occlusion. Then, if you don't address this nose, I don't think she will look any better even with the maxillomandibular advancement. So, you need to look at this nose, counsel and advise the patient accordingly, take it or leave it, it's the patient's prerogative. Because there are several issues here. There are surgeon factors, there are patient factors, there are monitoring issues. So, you advise the patient accordingly, it's an aesthetic consultation, it's not an orthognathic consultation. So you tell them that you need a malar projection, you need a nasal correction, you need upper lips to be plumped up, maybe fillers and things like that. You need an orthognathic procedure, you need a chin advancement, you need a sublingual lipectomy, you need a mini facelift, whatever. So you need all these soft tissue procedures, combinations of hard and soft tissue procedures to effect the optimal change that you want. So here, you look at the nasolabial angle. And just some examples that I've put here. Look at the nose here. This is also one of our old patients. It's by all means, even if I have to say it's a terrible nose. It's a very wide nose. By all rhinoplastic means, it is a terrible nose to correct. It's a nightmare for a rhinoplastic surgeon because of several reasons. One, it is very wide. 2, it's very thick skinned. I don't say Indians are thick skinned, but nevertheless, thicker skin is the nature of South Indian skin. So, this is a thick skinned, slightly saddle, very wide, no definition to the nose. And you wonder why I'm saying this. So, this is actually a class 3 situation, so to say. And if you look at I don't have the proper picture here. If you have to do a maxillary advancement in this particular case to correct the displaced deformity, you might end up with a nose which is so terrible, but you might end up with orthognathic or supplementary values which are normal. If you're trying to do that, you're not addressing aesthetics, but you're addressing numbers. So think about what you should do to camouflage the problem rather than actually go and correct where the actual problem lies, based on the soft tissues. So you're looking at the nose and then thinking about what to do to correct that class 3 deformity. Maybe you can go ahead and do the rhinoplasty at all and need be, and the patient agrees with the procedure. So this is something that I've not a picture of the tongue. There are many situations where you have patients with a large tongue, and particularly patients who have an open bite and a tongue thrust habit. With excessive proclination of teeth, you need to examine the tongue. So you can't go about doing even a segmental procedure, setting it back, because you might end up with problems subsequently on a late relapse situation. So look at the tongue, and if the tongue is huge, I remember one of our patients, we have also done in a class 3 situation, I guess, one of the patients was syndromic actually, where we had actually reduced the size of the tongue before we did the orthognathic procedure. I can't figure out the name of the patient. Reduce the size of the tongue and then do the orthognathic procedure. There are several techniques of doing tongue reduction and not going into details. Right? I just want you to realize that you need to look at the tongue as well. So before you embark on orthognathic procedures, remember that you have to make all these preoperative considerations, because I guess essentially the procedure in terms of the orthognathic procedure is dictated by these soft tissue considerations that you make. And having made these preoperative considerations, if you are thinking about the lip, the tongue, you need to make those intraoperative considerations as well, which means to say that if you are doing a maxillary advancement in a situation where you have to do it, you have to think about in a situation where there is gummy smile, take the maxilla up, intrude the maxilla, bring the maxilla forward as well, if it's a class 3 with a gummy smile. In which case you have to think about plumping the lip up, maybe doing a lip lengthening procedure. Maybe in situations you will have to do what is called a gingivoplasty if the clinical crown exposure is not much. So these are combined hard and soft tissue procedures that you can carry. And post-operatively, in those situations, you will have to think about some sort of physiotherapy for the lip procedures that you have done post-operatively. In situations where you have done a rhinoplasty, you may have to do certain things to improve the nasal profile. So I'm not going into details of that, but these are considerations that you have made based on the soft tissues. Now, look at this profile. This is the same girl here. A very bad nose. She has, you can see there is malar depression. Malar projection is not good, but she has got thick skin all over the face. Subcutaneous tissues are fat, plumpy, and that's her smile. She has nasal alignment, that. But then if you look at her profile picture after the procedure, it is a class 3 profile correction by instead of doing the maxilla forward, a mandible has been taken partially back because the degree of reverse origin was not huge. And what has been done to the malar projection is malar augmentation with bone graft, but also put implants. So this is camouflage the malar hypoplasty. And that's where from the pre to post-op, considering that bad nose, because the patient was not willing for a subsequent rhinoplasty procedure as well. I think this is one of the patient here. I put this picture to illustrate a point that she is a straight profile. Pre-surgical orthodontics has been done. Ethnicity is something that needs to be considered, but nevertheless, look at the profile. It's absolutely straight profile. Doesn't look, in a sense, class 3. Look at the nasolabial angle. It is much more obtuse, yes. But the profile is absolutely straight. If you look at her submental tissues and the distance from the chin to the cervical point, for a class 3 situation, she is pretty short on that. She is plumpy. She's got submental fat. And if you, I guess, take this mandible back, I do not know if she will produce an aesthetically good result. So I would recommend a maxillary advancement, because again, the extent of reversal is not huge in this particular case. So probably you can get away with a maxillary advancement, although you look at the nose, they are flatter noses, but then you can have a reasonable control of the nose with some marginal advancement. And that's the other position. And that is the circle branch in post-op situation. Sorry, and the orthodontic situation. This is the chart we saw earlier. Look at him again in this oblique and profile projections. Look at his smile. This was a case actually brought to me for bimaxillary procedure, for a maxillary advancement and a mandibular setback. So they said it will address all the problems that you see here. for which I actually declined. And this is him in the post-op situation. You can look at the profile, oblique and profile projections in smile. That's his occlusion. And guess what has been done? It is not a bilateral osteotomy. You will be rather blessed to know that I have just done 2 simple procedures to effect this change. It is just a lower segmental setback with what we call a malar augmentation with bone grafts. And this is what you see after about, the pictures after about a year's time. And that's his occlusion with just a segmental setback and malar augmentation. That's him in the profile. I guess it's a reasonably good profile in terms of the contour as well. And you can look at the redundancy of the lower lip that has been corrected by just a segmental setback. Now this is a sequence of slides. If someone is not very astute with clinical evaluation, something that you can do with a soft tissue analysis, but then the soft tissue analysis that you see with persons also has its limitations in terms of looking at only the profile projection. I think you need to look at the soft tissue in all 2 dimensions, the frontal and the lateral projections. And I think this is just, I don't think I'll go into the details of this, but you know, these are the lines. I think you should look at these things, look at the articles and train yourself to do this, because how you develop the aesthetic eye is based on how you train yourself over a period of time. And the pictures just illustrate these points in terms of the convexity of the face. So this will give you an indication of the convexity. The convexity does not tell you where the problem lies, but it's the maxillary mandible. This is again a diagram of the projection which indicates maxillary prognathism or prognathism. I'm not going into the details of this. This is just based on soft tissue profile analysis. This is the one which tells you about mandibular prognathism, something similar. I am not going into the details of these things. This is the vertical ratio which gives you an indication of what ratio of face is in terms of the third vertex, and this is particularly telling you about a 1:1 ratio. And that's the ratio from the glabellar to the subnasal and to the nathlon point. So essentially you should have a 1:1 ratio in terms of the soft tissues. Look at these 3 places. The ratios vary in the 2 cases, in the 3 cases. Look at this one, it's relatively compressed. These ratios will tell you where the problem lies, and then you need to analyze where exactly the problem lies, whether it is in terms of the height of the chin alone or the maxillary contributes to the increase or decrease in height of the face. Now, low face throat angle again. This also tells you the length of the cervical line and the height of this and the ratios with regard to these cases. I'm not talking about these details, but then these are things that you can do in terms of the soft tissue analysis to look at the profile and assess where the problem lies. Again, looking at all these in terms of the depth of the glabella, the nasolabial angle, the length of the lip, the mentolabial sulcus. I'm actually harping on the same issues that I spoke to you about in terms of evaluating the face, in terms of evaluating from a soft tissue standpoint. Nasolabial angle again. And this is just an idea that is given to you based on the soft tissue analysis by persons, which you can actually do without me. These are lines that are drawn to know the projection of the lower lip and the upper lip. It gives you an indication of incisive inclination, or whether the maxilla is forward, depth of the mental sulcus from that point onwards. It also tells you, you need to look at other things. You definitely probably need to look at the skeletal issues before you come to a conclusion in terms of procedure that you want to do. But then look at these. But you can see the mental sulcus is so shallow that if you do a mandibular setback in this particular case, you will have to probably bring the chin forward. And this is a case where you see there is absolutely flat mental sulcus and a very deep mental sulcus. Again, look at it in terms of the ratios. You might have a very short upper lip and an increased lower third, or you might have something which is very short here, long upper lip, short upper lip, and ratios might vary depending on the height of the chin. You can look at all of this. This is a class 2 situation, a double chin. The height here is more or less normal. This is, in terms of the height is fine, sagittally it is deficient. I don't want you to read through these things simply because this is the same thing what I said in the introductory part of this lecture. Now, zero median is again a line that is dropped to see the projection of the upper and lower lips, a line that traverses through the soft tissue nasion, through the ovonion, perpendicular to this FH plane. And you see where the problem lies. You don't need these lines, as I said, to know where the problem lies. Just you can eyeball these things. It's by all means not an interesting one because it does not have a definition of a nasal tip, and she would definitely benefit from a tip plastic. This is the girl that you saw here. Believe it, look at the lip. This is maxillary advancement. And this is the profile change. Look at the dorsum of the nose. It has given the nose a little more projection that you probably wanted. And what I'm saying is a desirable change to be brought about by addressing those issues, thinking about it preoperatively, and bringing in those changes intraoperatively. So you may have to look at trimming the septum, trimming the anteronatal spine in certain situations, leaving the spine alone, because you don't do it as a routine, just chop the spine. You might end up with a nasal tip which is drooping. You want a little more projection, do not reduce the tip of the nasal spine. It can be addressed by a simple angioplasty, and that's what one can do. Mesotomyopathy is something that one needs to know about in patients where you have a wide face, you want to narrow that down, because I think I have a lecture on square faces, I'll talk about that later tomorrow. Osteoplasty is something that can be done if you are doing in conjunction with the sided split, not necessarily as an isolated procedure. Perineal augmentation is sometimes probably done with the level 1 itself by keeping the anterior cut of the level 1 high up at the piriform basis. Malar augmentation also can be addressed if you are doing a level 1, which can bring the level 1, which can extend the lateral cut onto the malar projection, and that would circumvent the secondary procedure. Septoplasty is something that you can do if you are doing a level 1. Used diligently, you can have control of the nasal projection. Septoplasty is probably a procedure that can be done at a later secondary procedure as well. Only grafting is also something that one can think about. Now look at this particular girl. She has lip incompetence, substantial length of the upper lip, and that is her profile projection after mandibular advancement. I guess she needed a chin procedure as well. But for various reasons, the chin procedure was not done. I would think that she would have had a better contour of the profile. One had to do a chin procedure. But then you look at it from the front projection. She was actually a dummy smile. The extent of clinical crown show is less. So mandibular advancement in conjunction with just a gingivoplasty to improve the clinical crown length has brought this particular change. And gumminess has been addressed by a simple gingivoplasty procedure, mandibular advancement. And I wish I could actually also do a chin procedure to improve the profile. Look at this girl in the front projection. Nose, a terrible one that I showed earlier. She has delineation deficiency, and she has actually a redundant softish chin, which is substantially thick. If you look at her in oblique profile, you see that this is one of the most difficult moves that I've corrected. And that's the nasal projection with a horrendous grafting technique of cartilage graft, dorsal augmentation, skin plastic. A lot of cartilage work has gone through because it's a very thick skin nose, very difficult for any plastic surgeon. A malar augmentation has been effectively done with malar graft. And also you can see that chin enhancement with again genioplasty. Although one would, looking at her, would not vouch for a chin advancement. And that's the change that you can get with the 3 procedures in one. Look at this particular girl on to your left. This is the effect, a change that has been brought about with the maxillary advancement already. So that's the maxilla just come forward. I don't think she looks interesting at all with that advancement, because her nose is very wide, thick skin, flat, and this is her just with the touch of a rhinoplastic procedure, how she has changed from there to there after level 1 after. So you may have to do a soft tissue procedure subsequently as a secondary procedure if needed. This is the same girl I showed you earlier. She has had a mandibular advancement in this particular case, but the nose has been addressed later on. Nevertheless, I still would think that she would benefit from what I said is a maximum mandibular advancement and only a mandibular advancement. But the projection of the nose and the aesthetic profile is much better with rhinoplasty. The effective change brought about again by rhinoplasty alone. It masks the mandibular orthognathic. Another lady, a rhinoplasty, which masks the rest of the problems. Look at that saddling and the notching of the nasal tip. Look at the definition of the nose after the nose procedure. I put this picture to illustrate a point that you have a nasolabial angle which is reduced. Similar to the previous girl, there is a retraction of the national mandibular complex. He is a class 2 deep bite. I think I have a picture like to see. It's literally a closed bite, and this is the, look at this contour. Nothing interesting. So this requires an entire maxillomandibular complex advancement and a rhinoplasty. So you look at his redundant lips rolling in. And that's it with the mandibular advancement to augment the facial height. In these situations, you can sometimes, he was not going for a maxillary procedure, and the mandibular advancement has been done, creating a posterior open bite and an orthodontic extrusion to create an increase in facial height as well, and an added increase in chin height has been done. This is one of our students again. She wanted an effective change, and you can see that in the profile. A chin advancement with nasal correction. So what a soft tissue procedure can add up to. And that's in the profile projection with the chin and a nasal correction. Okay. This is an overt mandibular orthognathism. This is a chap who is about 5'10", nearly 6, tall chap, long face, therapy luminous, reverse overjet was about 15 millimeters. But then, look at his nose. From pre to post op, I think it's more or less the same. Look at his profile. I'm talking about the profile of the nose. More or less the same. Look at his reverse overjet that you see here. It's 15 millimeters. Chin height considerably reduced. Huge forehead, matching that. Look at the nose. Not much of change. And if need be, this guy can have a better nose with an anaplasty subsequently. Now sometimes you get very complex situations. You might get patients like this who come to you for orthognathic. And there are issues like this. Without addressing the other issues, I don't think you can look at orthognathic, which will correct these soft tissue problems. These are horrendous cases. And one needs to look at these cases very carefully before you actually embark on orthognathic, because you need to correct the soft tissues. You have a lot of limitations in this particular case, and a limitation in this particular case. This is the thyroid syndrome. I think you have the post-op pictures. You may have to combine these procedures. You may have to advise the patient accordingly about the hard and soft tissues and the number of procedures that they need to go through. And these are some procedures that you need to look at before we actually do orthognathic in situations where we have knee-wise, scars, and so many other things. So you have to sort of be sure of doing these procedures as well if you are doing orthognathic procedure in a situation like this. So this is that chap with the thyroid syndrome. He had a sort of lower third of the face, which is not interesting for him. And this is what you see after an orthognathic bimaximal procedure. But then I've addressed his forehead as well by doing 1, 2, and 3 procedures, correcting this deep ridges and furrows by doing different types of procedures. And that's his eye socket, which is also, in terms of its volume, different from the right. He's a thyroid disease, so he has got.
I'm sorry, I will leave you behind for some time. But thank you. He's a recipient of prestigious awards like Blue International Scholarship in Orthodontics, Excellence in Education, award presented by the Shiksha Samiti Trust in 2007-2008. Dr. Akshay has a clinical interest in adult orthodontics, high-speed, low-friction treatment, low visibility cosmetic orthodontics, and surgery post-orthodontics. Currently, he is working as a professor in the Department of RV Dental College, Bangalore. And I invite Dr. Shetty to speak on clinical evaluation and proprioceptive planning for orthodontic surgeries in different market regions.
Thank you for that. Good morning to all of you. I think that introduction was for my website, usually for marketing. Thank you for that very much. I'd like to thank Dr. Raj and Dr. Sidhu for having me here and inviting me to speak. My topic today is a very basic topic, a very textbook topic of orthodontics, clinical evaluation and pre-surgical orthodontics. So I'll try to keep it as brief as possible. It's often said that the best orthodontics and the most skillful surgery can be negated by poor pre-surgical planning. I think this holds good. Now this is a case who had come to the clinic basically for, he found it difficult when chewing. He felt that his teeth were not very visible. We ended up finishing the case because it turned out to be more, the problem turned out to be more than what it was. It was a complex problem. It was a problem with both maxilla and mandible. So we ended up doing the surgery, trying to increase his incisor visibility and solve his chewing problem as well. The emphasis here is not on the surgical outcome, but on the diagnosis. So what we need to do is to observe the discrepancy. So clinical evaluation will, in a broader spectrum, will involve all this. You need to have the patient chief complaint and expectations, then a medical and dental history, and the socio-psychological status. We were in conversation with Dr. Sidhu yesterday. He mentioned that when they started the orthognathic clinic here 2 years back, it was very hard to convince people. They didn't, in India, we don't need to convince just the patient, we need to convince father, brother, mother, everybody, and the cousin brothers. So that's what Dr. Sidhu was mentioning. It was a big Herculean task to get surgical cases to come in. So this is what we will evaluate: the general evaluation, where medical history, and dental evaluation we look at the periodontal status and the oral function. I'll be talking a little more on the aesthetic facial evaluation, like different types of analysis. So the clinical examination will be of basically about 3 things we look for: identify the health of the oral tissue, make sure with the gum support, periodontium, and all these things are fine, the teeth are fine. And the oral function, where we look for speech and mastication. And then facial aesthetics, where we plan to look at facial aesthetics with proportions. So the basic diagnostic records to start with will have the following: photographs, radiographs, and models. This is how general photograph will be. We'll have profile, smile view, and the intraoral photograph. The X-rays will be of important. You need to take a set, regular IOP and radiographs, and an OPG, a frontal set if required. It's very important to take these, because here is the case what I'm showing you is an OPG of a class 2 female patients. If you look at them on time, they're very, very good. Now these cases are not very ideal for surgery, so you need these records to look for all these problems. So if you further require, you can have a CT scan or an MRI imaging. So study models, usually you need 2 sets of models, one to articulate and one as a study task, just look at the health of the teeth. Now the need for these models are to record any sensory CRCO disturbance and to record the lateral and anterior exclusive movement of the mandible. The cephalometric analysis, once you take the record, you do a cephalometric analysis with the X-rays. You use the lateral step for this. You have measuramental analysis and template analysis. I'll be mentioning all this in brief. The measuramental analysis usually consists of the following: a composite analysis, a COG which is specially meant for surgical predictions, and a frontal analysis. The composite analysis includes dental, skeletal, and soft tissue parameters. The commonly used are Stinner, McNamara, Rossi, Gerard, and Wheat. The COGS, as what is called as Cephalometrics for Orthognathic Surgery, was by Charles Burston. These measurements can be easily, these chosen landmarks and measurements can be altered by various surgical procedures, and the measurements can be easily transferred into a study task for mock surgery. And for frontal analysis, we use Drummond's analysis, the PA set. Now, this is the envelope of discrepancy, what is given in most standard textbooks. The outer circle, which is red in color, denotes what is possible with surgery. As we know that the skeletal malocclusions come with different variables. You have the mandibular excess, you have maxillary deficiency for class 3s, you have vertical problems where you have dummy smile, you have deep bites, you have open bites. The next step is to record facial proportions and aesthetics. These are the following things we will be looking at: facial midline, the horizontal third, paradoxal area, cheekbone, nasal, base left contour, and the facial contour. Now for pre-surgical measurements, when a patient walks in, once you have his records, the first set of you need to have these 3 things. You need a scale, a caliper, and a floss. So So what we do is, the first thing is to record the facial midline. The midline, as shown in the diagram here, is drawn along the center, that's on the glabella, nasal projection, right in the center of the face, to keep it as simple as possible. So this is how we do it. We take a floss and we put it on the glabella, nose and filter it down the chin. Then we look at the dental midlines. We check whether they're matching. And these are for vertical proportions. We draw horizontal lines and we check whether there is a decrease or increase in the lower part of the face. We check for CAD by placing a scale in the mouth, and we use a caliper from the inner canthoceptal eye to the canine, and we check if there's any transverse discrepancy, any CAD in the occlusion. Then we check for incisors show at rest and smile. Usually the lips, the upper tooth to lip relation, usually the lips at rest should be at rest and relaxed, and a minimum of 2 mm incisor exposure is desired at rest. We also look at the smile. For more consonant smile, we follow the smile arc. That is, the upper teeth follow the lower lip, the curvature of the lower lip. And the next set of measurements is the rule of fifths. The advantage of this is what you have is you have about 6 lines over here. Each line is the width of an eye. So what you use this for is actually the inner canthus of the eye. This line is actually showing that the nose should be within this line. If the nose is within this line, as shown here, then it's a more spherical thing. If the nose is outside this line, as in this case, if you bring a maxilla forward, the tendency to increase the alar base, so this should be taken into consideration. And this outer canthus of the line should be in line with the gonial angle over here. Usually with patients with square-shaped jaws, this angle is a little outside the line, and you need to trim that to get into the line. So this is how the rule of fifths take. It's mainly meant for transverse dimensions. And this is a general percentage. What we do is the binomial width and the bisegmental width. Usually females it's about 1:3:1, and males it is a little more, 1.35:1. So the bisegmental width should be a little more than the binomial width. And once you've done all these measurements, you need to put in a piece of paper like this. So you write all your according to your incisor show on rest, smile, make sure that the midline is on. If there's any categories, record that as well. Once we do that, we need to record the paranasal area. The paranasal area is a line from nasal projection and subnasal. This ratio should be always between 2:1. That means the distance between these two lines should be more than this. What usually happens is, ideally the paranasal area, the line should be the ratio as 2:1, like I said. If these lines are equal, it indicates a maxillary deficiency in anterior posterior plane. Okay. If all factors are equal, the class 3 patient with decreased nasal projection, that is, this lines can be equal in one condition where the maxilla is back, in another condition where the nose itself is short. If the maxilla is back, then you need to do a maxillary surgery to get the proportions back. If the nose is short, then a maxillary surgery should be avoided. It's more suitable for a mandibular surgery. This is another important criteria for aesthetic evaluation. So you have a line from the zygomatic arch to the middle area, the subpupillary area, and here is a breaking point for the maxillary projection, and then you have the line over here, which is the lower part of the face, below the nasal base, and on top of the upper lip corner. So in a normal case, this is how it should be. Usually you tend to have a smooth curvature. But in cases with the maxillary protrusion, you can see a slight dip over here as shown. suited for maxillary advancement. This is another feature where you have a double break. Here is a bijaw problem where you have a maxilla which is back and a mandible which is forward. So you see the curvature follows the back. So there is a double break. So these cases usually will benefit from a bijaw surgery. Now, when patients with parafacial deformity and lack of cheekbone, another interesting thing to look for is, when your particular attention should be paid to patients to the suborbital area, evaluating the characteristic of inforward rim and determine the presence of otherwise sclera exposure on inforward. They tend to have more of the sclera. When you have a mid-face deficiency, you tend to have more of sclera exposure. This is something you can look for. I don't know whether it's consistent in all patients, but most patients with a lot of mid-face deficiency tend to have more of sclera exposure. So then, chin throat angle, which is acute in mandibular axis and obtuse in mandibular deficiency. This is very important measurement because when you do a setback, you should make sure you don't have double chin. And these are your aesthetic lines, the S line and the E line, which is basically showing that the lips are protrusive, that the insides are forward backward. And the next measurement, I think, is already spoken by the previous speaker. The facial contour angle is basically showing the angle of convexity. The lines are drawn from the glabella to the subtextual and another line pogonium through this. If this line is usually forward, in normal cases it's about 11 and minus 11 and 4. If this line is ahead of the G, it's shown a negative sign. Usually for males it's more straighter, for females a little convexity is appreciated. In class 3 patients, this line lies somewhere over here, showing retrusion. Now, coming to the treatment planning, the first step is the vision treatment objectives, the video is to be established. This was given by the kids. This is more easier than a classroom phase where you can actually visualize yourself by asking the patient to bring the jaw forward and see if the profile improves. The other methodology is to use cephalometric prediction. We use tracing overlay method and template method mainly for mandibular surgeries. An overlay method is used for both jaws. This is what you do. You draw the outlines of the skeletal structures, and then you perform a surgery on the paper, and you see which is the best fit and look at the profile. Usually, there's a chart given that if you move a skeletal structure by so many millimeters, there is a soft tissue changes accordingly. So we follow the chart and we come to a reasonable prediction. For those of you who think this methodology is outdated, they use computer simulation to achieve the same result to see whether these things work. Now, usually the consent form prior to taking the patient problems has to be recorded, a proposed treatment plan by the surgeon and the orthodontist, the benefits of the treatment, the risk involved, and the cost should also be mentioned. So coming to preparation as an orthodontist for these surgical cases, as we know, the orthodontic treatment precedes and prepares the dentition for orthognathic surgery to correct skeletal-dental discrepancy. So, the pre-surgical orthodontics includes the leveling. You can have teeth in various forms. There will be crowded teeth. You need to level them, align them. You need to establish an anterior, posterior, and vertical position of the teeth and make sure that the arches are compatible. Now, the best appliance suited is a pre-existing advice appliance. Any slot can be used. Now, usually leveling involves removing any curve of speed in the lower, but it's often advantageous to use surgery to level the arch rather than move the teeth. The vertical position of the lower incisors will determine the facial height. I'll come to this a little later in detail. So either you can use a continuous arch wire, a segmental arch wire is also preferred, and then they have two occlusion planes. Now the arch compatibility, both maxilla and mandibular arch should be coordinated. Sometimes the teeth are tipped buccally, a pelvic cusp hanging in cause of occlusal interferences. Expansion should be limited with orthodontics only 2-3 millimeters per side, not more than that. Now the anterior posterior position of the incisors determines the extent of how much the jaws can be moved either forward or backwards, and you need to decompensate if any compensation is occurring. So in a nutshell, the primary objective of a pre-surgical orthodontist is to establish maxillary and mandibular teeth in optimal alignment, inclination and angulation before surgery. This involves removing any existing dental compensations. So what do we understand the word compensation? See, sometimes teeth naturally compensate in an effort that teeth move in an effort to mask the skeletal problems and try to establish themselves as the best possible occlusion. So usually in a class 2 case, I think the next speakers will be speaking about compensation, decompensation in detail. I am having a brief of this. Usually in a class 2 case, you have both procline upper and lower incisors. The molar relation can be class 2 or class 1. Usually the skeletal problem appears less severe than what it is. So you need to manage the case in 3 planes, that is anterior, posterior, vertical and transverse. So usually anterior posterior, you need to position the incisors in an anterior posterior dimension. This determines how much of the jaw can be moved. So you need to remove all dental decompensation or compensation that has occurred. So in a class 2 case, usually the lower incisors should be moved back so that you have an object where you can bring the jaw forward to correct the malformation. In a vertical plane, positioning the teeth in vertical dimension actually determines the facial height. So if you have cases with short facial height, it is better to extrude the teeth after surgery. In patients with long faces, it is better to have inclusion of the incisors prior to surgery. So this is a general rule. Now, like I mentioned, in transverse plane, orthodontic expansion should be limited to 2-3 millimeters per side, or expansion should be done surgically. Anything more than this should be done surgically. So usually the extraction pattern in a class 2 case, where both upper and lower incisors are upper 5 and lower 4, that means you need to bring the molar teeth forward and the lower incisors backward. So this is a case where this is a class 2 case where a minimal decompensation was done. So here there is no extraction done. You just need to align the teeth and then do the surgery. So what you do is you create an object and then bring the jaw forward. So this is how we align the case, coordinate the arches, align the teeth, create an object as seen. And this is following surgery. Now, in a class 3 case, you have compensations which are caused by flaring of the procline upper teeth, reticline lower teeth, and sometimes a posterior crossbite. Once again, the skeletal malocclusion appears less severe than what it is. This is a classic class 3 case with procline upper teeth and reticline lower teeth. Usually, the first step will be to align the arches, to remove only decompensation, to level the teeth, and make sure there is transverse coordination. So in the anterior posterior plane, like I said, you have planned the case in 3 planes. You should position the incisors in a proper anterior posterior dimension, which determines the amount of surgical correction. So usually in a class 3 case, removing dental compensation is lower incisors should be proclined, and you need to create a reverse overhead. And the upper incisors need to be retracted. So usually the extraction pattern is the reverse as in class 2, where the upper 4 teeth are removed and lower 5 is to create a class action and to create the reverse overhead. This is how prior to surgery case looks. Now, as we know that in class 2, you can ask the patient to bring the jaw forward and to make sure that the arches are coordinated. But in class 3, it's a difficult thing. So what we need to do is we take a study class prior to surgery, and we see after setback what would be the best type of occlusion. So the better to coordinate the dental occlusion outside the mouth. So you make sure that there's good intercustation of the midlines are matching, and the molars are in the right elevation. how we finish the case. Now, coming to long face syndrome, the long faces usually occur when there is an inferior rotation of the posterior maxilla, hence the mandible is wedged back. Because the mandible is wedged back, there is a reduction in chin prominence, and hence more anterior posterior problems are seen. Usually the lower incisors are upright and crowded. Now these cases, the long faces usually tend to have an open bite, a deep bite, a gummy smile, a narrow maxilla, and a tendency to posterior cross bites. So treatment options are usually a leaf forward one, osteotomy with a mandibular advancement, a SAG done, and a genioplasty to improve the chin position. Now there are two things you must know. Is the maxilla going to be kept in one piece or is it going to be sectioned? If so, how many sections? Now is the chin position going to be changed or is proper lip chin balance going to be achieved by orthodontic treatment? Now the pre-surgical orthodontics in this usually alignment of arches segmentally and decompensation to correct incisor inclination and transverse coordination. So usually this is a classic an open bite case, skeletal open bite case, and you can see there are two occlusion planes, one posterior and one anterior. So usually it is best suggested that get your orthodontist to align them segmentally. So mandibular molars can be banded before surgery, maxillary molars after surgery. Now this is a case with vertical maxillary excess, class 2 molar relation and hardly any overjet. So the surgical plan for this was V4 point superior repositioning to correct gummy smile and the auto rotation of the mandible with BSSO and mandibular advancement. So what we need to do is create an overjet anticipating this, and this is following. So you can see the gummy smile reduced. This is another case where she had problems in 3 planes. All problems in the 3 planes. So there's gummy smile, there was anterior excess incisor. Then pre-surgical orthodontics was segmental procedure. Teeth should be leveled with the segments. So what we did was we leveled them separately. And this is how the case looked prior to surgery. If you see that the roots are deliberately kept divergent, this is what we need to prepare as an orthodontist so that the surgeon can make the cut. So in segmental surgeries, it's better to establish position or torque of the incisors prior to surgery, and about a half of the extraction space should be left open. So this is how we finished. Now at the end of the pre-surgical phase, the patient should be in a full-size rectangular wire which will help to stabilize the teeth during surgery. So this is how the setup should be prior to surgery with the heavy base arch wire, preferably a 1925 in a Ortho slot or 1725 in an overlay slot with clippable stops. So this is your basic setup prior to surgery. And your pre-surgical record should involve an OPG, a lateral cephalogram, photographs, and the final pre-surgical preparation should be pre-surgical records, model surgery, splint fabrication, and stabilizing arch wires. So the common question with most of us have is it must to finish all cases in class 1? Well, the answer is no. Class 1 canine is necessary, but class 2 molar relation can be acceptable in certain cases. I like to conclude that once the teeth have been positioned in an ideal relation to their respective maxillary and mandibular denture base, the dental restrictions imposed for surgical correction of the jaw discrepancy are eliminated. Without these tooth movements, the surgeon is limited in correction of jaw discrepancy owing to the interference from the teeth. Thank you.
First, I would like to thank Dr. Raj, I would say the case 2014 team, and I would like to thank you for inviting me for this lecture. basically a clinician. I don't measure more of these angles, lines. Since I do exclusive orthodontic practice, I'm more into the private practice. But I do visit some of the academics when it is required. My topic today is orthodontic preparation of the patient for the orthognathic surgery. Dr. Akshay has spoken a lot about the pre-clinical evaluation, but I've taken a part of that, and that topic is the compensation and the decompensation. And I thought that there are a lot of students here. You need to really concentrate on this compensation and decompensation. If you are good in compensation and decompensation, the treatment planning will be really excellent. You are making the surgeon's job very easy. What I'm going to do is, I'm going to talk to you in a very simple manner where you can easily understand with some good animations. As we know that the child starts growing, you keep observing the skeletal problems. When you see that there's a growth problem, you really modify that growth. That growth modulation will go to correct most of the problem. Sometimes, if you just leave it like that, it keeps becoming worsening, and you will try to do some complex treatment when they become harder. Then the worst comes worse, you are forced to avoid doing orthodontics, but you should try to convince the patient for orthodontics and orthognathic surgery. So by making use of your good diagnostic skill, acumen, and good intervention in your treatment plan, you should think of doing orthodontics and surgery. What is compensation and decompensation? In many cases of your severe jaw imbalances and resulting malnutrition, the teeth are inclined in such a manner as to partially offset the discrepancies. By definition, nature tends to compensate for the deficient jaw by proclining or retroclining the anterior teeth, and this is termed as compensation. It's quite simple. For example, if you take a case of skeletal class 2, where the jaws are not properly positioned, but teeth has got a tendency to get adjusted to that jaw position. So that is called compensation. I would like to show you here with an animation, you will better understand. Now this is the malposition jaw. You will see the prognathic maxilla and the retrognathic mandible. But these teeth are aligned in a manner where it is more of a class 2 relation. But whenever you have a skeletal problem like this, the anterior teeth, you need to concentrate here. The anterior teeth tries to retrocline. The upper anteriors will try to retrocline or upright. But the lower anteriors will go to procline too much forward. At the same time, the posteriors also try to move. Just see that the anterior aspect of the maxilla, see how it is moving. Now this is the compensation that has taken place for the skeletal manipulation. When you come to a case, I'm just showing you here one simple case where she's got a deficient mandible, normal maxilla. Because of that deficiency, she's got a skeletal class 2. The upper anteriors are not proclined very much. It's almost upright, or I would say a little bit proclined. But the lower anteriors, it is almost proclined too much, and there is a severe deep bite. Now in these cases, you should think of doing decompensation. I'll come back to the decompensation. This is as far as this class 2 is concerned. When it skeleton, definitely there is a deficient maxilla and a orthognathic mandible. What happens? The upper anteriors will go into procline a little bit, and the lower anteriors will go to retrocline too much backwards, which will be in a reverse overjet or it will be the extreme line. If you see this animation, you'll better understand this is a retrograde maxilla and a orthognathic mandible. Please observe the anterior part of the teeth here. See how the compensation takes place. The upper anteriors will go to procline and the lower anteriors will go to retrocline, and it will be on the H2 H5. Now these are the two compensations that you can see with a class 2 and class 3. Now you can see the picture also here, how the teeth are upright, or I would say mildly proclined, but the lower anteriors are severely retroclined. When you see this compensation, so patient will continue with these compensations. But as an orthodontist, it is very important we need to do a good decompensation. In order to achieve ideal inclination of upper lower anteriors and to facilitate the ideal jaw repositioning during the surgery and to get exact class 2 or class 2 relation, the teeth are brought into ideal inclination either by proclining or retroclining, and also by extracting the root teeth with the mechanics. And this is termed as decompensation of reverse orthodontics. The definition is quite long. The procedure worsens with the maxillomandibular interpolations. As we know that this patient requires decompensation, definitely the will be spoiling their face, but not to worry about that. Now if you see here, the maxilla almost looks normal, but there is a deficient mandible. But we wanted to bring the mandible forward, but there was not much space where we can advance the mandible. In fact, this is one of the Dr. David's case. He has asked me to do a decompensation and said, Rajshekar, you need to do a good decompensation. I need to move the lower jaw forward, because the patient was also fussy about his profile. Now, decompensations, once again I am going to classify into class 1, class 2 and class 3, because you need to know for all the cases. The first one I need is class 1, gum is mine. The common problem with the patients is that they say, Doc, my gums are very bad, but can you do anything for this? The first and foremost thing is, we come to know that there is an endowmolar relation or mild class 2 relation. In such cases, what we need to do is, we need to do the treatment non-extraction. So when you try to do non-extraction, definitely you need to use elastics. For example, if you take this patient, she was treated earlier by somebody and she was not happy with her profile. The basic thing was they have done a mistake with the diagnosis. So what we need to do is, we need to strap up the case. Strap up the case, both upper and lower, level and align. But I have a series of wire segments here. Initially, I always go with 0, 1, 6, 9, then I go for 1622 stainless steel with heavy class 2 elastics. Now you have to know the rule here when you are doing orthognathic surgery. Definitely you should use heavy elastics. Heavy elastics, when you use a class 3 elastic in this patient, there will be good amount of overjet will be created. That is, you are proclaiming the upper anteriors and retracting the lower anteriors, creating sufficient overjet. Most of the patients, when you do regular orthodontics, you always keep class 2 elastics. When you keep class 2 elastics, the upper anteriors will be retracted, but the lower anteriors will try to proclaim along with the curving the sphere archway. Whenever you do So in case of a gummy spine patient who has got a mild end-on relation, you need to use class 3 elastics. Create more overjet. Once you create more overjet, the surgeon will have good space where they can include the maxilla and set back the maxilla. So after doing that, I subject the patient for the surgical procedure. Before I send the patient for surgical procedures, I always put 1925, a stable wire with the hooks. As these hooks are very useful for the surgeon, where they can do intramaxillary wiring or they can use the elastics for the intramaxillary fixation. So once we do that, once we send the patient for a surgical procedure, the surgeon will go to do the surgery, then they will come back to us. Then I use over 6 stainless steel settling arch wire and I use some elastics to have a better finish. So this is how I am going to do. This is after leveling and aligning. I just put the base arch wire 1925, then I put 3 cover hooks. Now once this is done, we'll send the patient for the surgery. And after the surgery, she looks like this. You can really appreciate. In fact, this slide I'm not supposed to show. The surgeons are supposed to show this, the severity of the gummy smile, and here how the visibility of the gums is gone. Now, when you come to another case of gummy smile, this is a very interesting case. You should really know. This is more of a biomass case with a severe convex profile, incompetent lips, and severe gummy smile here. There is severe crowding of the cheek, and the teeth are very badly profiled. So, what I have done in this case, the treatment plan is slightly different. Here, I did the leveling and aligning with the 016 NICA wire. Then I used 1622. Once again, I did the leveling and aligning. Then I went for the 1725 arch wire. What I have done here, I have not extracted the upper first premolar. I have extracted only the lower first premolar. Why I have done this is that I want to maintain the overjet. To maintain the overjet, what I have done is I have retracted the lower anteriors. So all the lower anteriors have been retracted. You see how much the overjet that has been created? This is because this is the understanding between myself and the oral surgeon. We do a lot of discussions, we try to do different methods. So what we planned is we wanted to do 2-piece intrusion of the maxilla, allow the mandible to auto-rotate. But I have changed the treatment plan in this. Going with the severity of the crowding, I have extracted the upper second premolar here, upper first premolar here, and lower first premolars. This all depends how good in your orthodontics. There is no hard and rule that you need to follow a textbook method. If you have your common sense and you can move the teeth in different directions, you can really do wonders. So what I have done is I have extracted such teeth and I have aligned all the teeth. After aligning the teeth, I have already gone for a base arch wire with a grippable loops. You can ask me, what about the extraction space that you have not completed but you are referring the patient for surgery? Yes. I couldn't do closure because there was an obstruction in that part, in this part. I was not being able to retract or protract. There was a locking mechanism that was happening. Then I referred the patient for the surgical procedure and the surgeon, Dr. Kishan Naik, he is the one who does this, all my cases, most of my patients. So then he did the surgery. You see how beautifully we got a classroom relation. Now after doing that, the surgical procedure, he is still in the recovery phase. You can just see the suture materials, but still the extraction space is not closed. It is my duty to close the extraction space. You can see that extraction, so much extraction space is there, but still I could easily close it, that was not a problem. Now whenever the surgeon tries to do the treatment, if there is deficiency that has to be tackled by the orthodontist. We need to work it out on that. Whenever we are lacking behind with some procedure, the surgeons will going to help us out. So you need to have a very good coordination with the surgeon and the orthodontist. Then only you can really do wonders. So this is how we will finally finish with a good occlusure and a good profile. See, you can see that you can appreciate these spaces that has been completely closed. Now, this is again one small morphing, you can just see that. How the jaw can shift to the normal position. Now, coming to some mutilated cases where there is not be proper occlusion or severe crowding, such things, you need to first do the decompensation by just aligning the teeth. Whatever the best of the teeth you can align, you just align. Whichever the teeth has to go for extraction, just take it out. The rest all you can decide on the treatment planning later. See the amount of crowding. This case, we have done some maxillary advancement. This is the pre-treatment picture, okay? So what I did is I did the leveling and alignment of all the teeth. Then we did the surgical procedure. Now, this is all about both the molar and the incisor position. All this time I was talking to you in general. But we need to concentrate mainly on the incisors. Now, in a skeletal cluster patient, the general normal patients are usually expressed as protrusive mandibular and upright maxillary incisor. That is what I was talking to you in the class 2. A critical part of pre-surgical orthodontics involves the removal of these incisor compensations. Failure to place the teeth in the ideal axial inclination prior to surgery may severely limit the amount of surgical skeletal correction that can be achieved, thereby producing less than ideal aesthetic and functional results. Now, this is mainly for the orthodontist. When they want to do class 2 corrections, what are the best way they can do it? So for their information, I just provided this information here. Upper entails can be proclaimed with increase in the curve of speed. Then use O6 round wire, heavy class 3 elastics, and retract the lower anteriors. In case of class 3, once again increase the speed the arches for the lower teeth, not for the upper one. There you are using it for the upper one. Use of class 2 elastics and a labial crown top. You can give in 1725 or 1925, you can give a labial crown top so that you can upright the lower incisors which are inclined backwards. Okay? And use a reverse curve. You can use a reverse curve of Niger also. Now I am going to show you this one more case here. This patient had a class 3, and the upper anteriors were retracted. This was also a treated case. My patients, most of my cases, I almost 80% will go for the non-extraction. It is very simple, you can do that. So you have to have a lot of confidence in doing surgical cases. If you can just start with 1 or 2 cases, you can do hundreds of cases. And you need to have a good team of surgeons where you need to coordinate. So you have to sit and discuss with the surgeons. Definitely they are going to help you out in doing good changes. So with this, I would like to conclude the decompensation and compensation and decompensation. And if you have any questions, you can ask me.
presentation is purely about box surgery, or modern surgery, stimulation surgery. So this is mainly for the postgraduates. It's purely a lab procedure which I'm going to show you and how to do it, and an easier way of doing things. So today's presentation for this section will have the following things. There are general rules for these modern surgery. A little bit of face port transfer and its importance. Then I'm going to show you a mock surgery itself and how to construct wafer split. So like I said, it's more of a lab procedure. So let's start with the general rules. Any surgical movement should be greater. If any surgery has to be required, the movement should be greater than 3 millimeters. Otherwise, anything less than this should be done orthodontically. Any surgical movement that is done between 5 to 10 millimeters, more than 10 is extremely unstable and can be subject to relapse. So the optimal amount of surgical movement is 5. When I say optimal, it means ideal. So it's easy surgery and more stable results. Now, only an anterior segmental osteotomy does not need a face bone or an articulator. Leaford one osteotomy or a two-jaw surgery requires both of these. What we do is, like I mentioned, we do a paper surgery, or you can use a simulation surgery by using computers. Once you do that, and quickly you're going to run through this, you do pre-surgical measurements. Like I mentioned, you check for the maxillary can, make sure that everything is fine and nice. Check for the midline, check for any facial asymmetry, check for dental midlines whether they are matching or deviated prior to surgery, check for incisor show at rest and smile. And once you have done this, all these need to be recorded on a piece of paper. So this is your information, what you have prior to doing any model surgery. Now the next step is face port transfer. Now, what is this? It's an instrument used to register and record the positional relation of facial maxilla to the base of the cranium and to mount the same relation to an articulator. So basically, you're recording a maxillary position of the patient and taking that same record into an articulator. So as we know, this is how a face port looks. It's got a bow, it's got a white bow. You use a silicone material and use a white bow with the silicone material. Mark the midline. Then you take a squash bite, so you need these two things. One is on the white board and one is a regular bite. Once you've done this, then you do the face port transfer. Traditionally, the older face ports came with an orbital pin. Make sure that the bow and the equipupil line are all parallel. The others, what we use is got a, instead of orbital pin, it's got a nasal, it's got more of a nasal marker. So once the face port is placed into the earpiece, make sure all of them are parallel. And once this is done, this particular record is transferred onto your semi-adjustable articulator. Now, once this is done, the next step is to prepare your model. So what you need to do is you need to pour a nice base, use a base former. And then you make sure that the base and the occlusion plane are almost parallel. So you wet the model, put a little bit of Vaseline so you can separate the model later on. Then you mark the midline. You mark the midline on the plaster, you mark the midline on the model as well. So you make sure that the midlines coincide. So you have a prior setup, you know exact position of the plaster which you use to mount onto the articulator, and you have the regular stone cast. And you make sure that these two lines are marked. So once this is done, you position the stone model before you pour the plaster into the right fork. What we use is, we use two instruments. I think it's a very easy way. You can buy a glue gun, a silicone glue gun, and you buy a good adhesive tape, I think a Scotch tape by 3M, which is strong. So what you do is, you need to wrap the Scotch tape around the model. The idea is you're creating a platform to pour the plaster. So you do a clean job. It's not a messy job. It's nice and clean. So So the idea over here is less work afterwards. You don't need to spend time trimming it, wasting time. And then you make some small indentations because the plaster is pretty strong. So when you put it on the articulator, you make sure when you close the articulator, it flexes. So you make small cuts all over. So once that is done, this is how it looks. Then you pour the plaster into that. So usually, if you're teaching this in the best way to do it, you make sure that your work is limited, your lab time is very less, you make sure everything is easier. Make sure that tape what you use is very strong. So usually a 3M Scotch tape which is easily available is the best thing. So once you just fill the plaster, then you let it set and make sure you tie the thing so that it doesn't expand and the inside of it comes out. Then you take the bite what you take, if you remember the earlier picture, I've taken a regular squash bite with you make sure you trim the excess of material all over. So you need to skin it. So this is how your model looks once it is ready, nice and clean. And then what you do is you use a glue gun to mount the articulator. The glue gun is, I think it's readily available in any shop. It costs $120 with a few silicone sticks. The advantage of this is if you're not happy, you can peel it off, put it again, peel it off, put it again. If you're not using a sticky wax, which is a little more messy, it gets into your teeth, it gets into your occlusion. So once you do that, then you pour the mandible in the same methodology, put a tape around it. So you actually glue the maxilla and the mandible pieces together, the upper and the lower class. Then you put a tape around it and then you mount the mandible in the same way, in the reverse fashion. The next step, once you've done it, you set up the model, is making reference lines. If you remember, I showed you a piece of paper where you've recorded all your pre-clinical measurements. Refer that, make sure the midlines are matched. Check for any CAD, check for incisors, show, rest, everything. So what you need to do is you need to mark accordingly. So you have vertical lines. Usually, earlier we use a combination of vertical and horizontal lines, but here we use only vertical lines. So the facial midline is marked in red. The facial midline is marked in red. If the incisor, if the teeth are deviating from the facial line, you follow the red line accordingly. Then you mark the long axis of the molar, the long axis of the canine. Then this is the frontal portion of the model, where you mark the long axis of the two central incisors, and you mark the line behind as well. So this is the same thing in the lower cast, canine, molar, and in the front, the facial midline, as you can see here, in this case it is matching, and the long axis of the two central incisors. Extend the facial midline and dental midline match, extend this line along the palatal surface as well. So you have markings in all sections, so you know how to mount the cast. So when you split the model, make sure that the plaster and the stone coincides, these two reference lines. So what you do is, this is a case where we need to do a bijaw. You have a leaf on one superior infraction, an advancement, and mandibular setback. So the model surgery, what I'm going to show you is for this particular case. So for a leaf on one impaction, the marking technique is we use a caliper. So I'm going to play this on the video. So what you do is you measure how much you need to trim off, how much of the superior impaction you need to do, turn the model upside down, hold the calipers tightly, and just move it around. So what you do is you can see that groove which is forming. So once that is done, you trim that particular thing. And this is how the following trimming, how the model looks. Now, for marking advancement, you use the caliper again when you're doing a model surgery for advancement. So this is what you do. You take the caliper, calculate the amount of advancement you do. So you make a groove on top of the base of the cast. Drag it all around. So you get an act, basically you set your caliper to a specific millimeter, you scratch it around fast. Once this is done, then you take a piece of pen and you mark that groove in black or whatever color so that the contrast is there, so you know exactly where to do it. And this is the amount of advancement that is calculated. You can see that this is the posterior superior impaction which is done, so the height is automatically reduced. And this is the advancement. You can see that the green stone is a little ahead, so you mounted it exactly. Once this is done, then you take a glue gun and you glue the area. Like I said, the glue gun comes in different gauges, so you make sure that you buy something that is used for more for craft surface. There's an industrial purpose as well. They're very strong, so it's difficult. So you take a glue gun which is easy to manipulate. So once you have done it, then you take your caliper, measure how much of vertical impaction is done. Measure in all sections, molars, canines, anterior segment. And once this is done, when you put it on the articulator, as you know, when you superior impact the maxilla, the mandible auto-rotates to a certain degree. So initially the incisor is set at 0. So once that's released, you see before you release it, this is how this shows the amount of impaction that is there. You can see the inter-occlusion clearance between the upper and the lower model. And once the model is released, the mandible auto-rotates. So you have a fair idea that its mandible is auto-rotated to a certain degree. So once this is done, this is where you do your intermediate split. That is, this is a split for the maxillary. Remember, this is a wide-jaw surgery. This is the intermediate split. The next step is, like I said, that this was wide-jaw surgery, it was a BSSO setback. So what we need to do is, when you're doing a modern surgery with this, you need to see the best fit. Where, like you mentioned, you don't have occlusal interference. You try to see the best fit. So accordingly, you do it once you're happy. You glue it all. You glue it all over that. And then you place it back. And you place the plaster model back. So once you've done the setback, then you can mark the chin area and you see how much of rough idea, what you think is a chin area is, you see how much of setback is happening in the anterior section. Then you glue the area up. This is how it will be. So this is a Leapfrog 1 osteotomy, advancement, superior impaction, antemandibular setback. Once you've done that, you glue the area with the glue gun. So you don't need to put plaster. You just use the glue gun. So if you're not happy, take it out, put it again. If you're not happy, take it out, put it again. So it's not messy. So this is how to calculate the amount of setback that is done. So you measure the vertical lines, use the caliper. Now when it comes to segmental osteotomy, what you need to do is, it's very important that you mark the roots. So you know that when you're using your blade to cut the section in the model, you don't touch the roots. I think this question was asked in my earlier presentation, how much of space required? And the answer was 2 to 3 millimeters. That is enough for a saw to run through. So what you do is you need to trim it in the right angle. Don't make sure that it's not oblique so it doesn't fit. So don't try to create too much of it. You make it oblique if the sectioning is not perpendicular. You create a bony gap, a bony stem, which is not good.
Maxillofacial and facial cosmetic surgeon of international repute. His BDS from Government Dental College, Trivandrum in 1974, followed this with a master's in oral and maxillofacial surgery from Kasturba Dental and Medical College, Manipal in 1978. He was the former president of the Association of Maxillofacial Surgeons of India and Indian Society of Facial Plastic Surgery.
Dear colleagues, friends, I will talk to you about the treatment plan of orthognathic surgery clinical criteria. As this is a short lyric that I have to tell. Received a special sensory reception, face moves with fine human expression, as humans climb the ladder of evolution, chose linear function. Size separate a gradual direction. Brain enlarged for better cognition. The evolutionary body present smiles was unique gain. You know that smile is unique things that humans have watched. When you talk about clinical criteria, I think that one of the most important things that you have to take into consideration is the occlusion, through which basically the function comes in. So we have our class 1, class 2, class 3, etc., which I will not describe to you what that is. Now, once you analyze the occlusion, then you have to look at the face. And basically the occlusion is mostly looked after by the orthodontists, while the maxillofacial surgeons have to look into the face. And the bone structure, that is the basic framework, bone structure and framework of the face. But one important thing that we have to consider is that, yes, the bone structure of the face is very important. But at the same time, none of us have got an X-ray. So we are not able to see the bone. But the tissue, and the soft tissue around the bone is the most important thing. So that is what patients come for, basically. It is not basically the function, but it is basically for aesthetics that a good number, I would say that 95% of the patient comes for aesthetic reasons. So one of the important things that you have to look into is the nasolabial angle. You all know that it is something between 90 to 110 at the norm. But it depends on so many factors. Like one of the most important factors is definitely the protrusion of the upper anteriors, and then the angulation of the column. So these are the two things that you have to consider. So that is only one of the criteria which you have to take into consideration. So if it is less than 90, you may consider that there is an occlusion in excess of the maxilla. Well, definitely you have to consider the columellar angulation as well. The next point you have to consider, this is probably one of the most important, lip position. So, difficulty in closing the lip is one of the important things. When a patient comes like this, it could be because of two reasons. It could be a short lip, or it could be because of the excess of the maxilla. In majority of the cases, it is the excess maxilla. And short lip is something which is very difficult to manage. But an excess of the maxilla, vertical excess of the maxilla, can be easily corrected by the one osteotomy. So this is lip incompetence is one of the most important clinical criteria for vertical maxillary excess. And of course, the gummy smile. Gummy smile can be again because of two reasons: vertical excess of the maxilla, and at the same time, hyperactivity of the levator muscles. Facial proportion. This is everybody knows that the face can be divided in three equal parts, from the hairline to the glabella, then the subnasal, and to the menton. So this is something which you have to take into consideration. This particular part, because of the hair style and so many reasons, we don't take it much importance. But this portion and this portion is taken into consideration. And again, this from the subnasal to the upper lip sternum, which is 1.3, 1/3, and from the lower, from the sternum to the menton, it is double of that. So these are the certain proportions that we have to take into consideration when we are planning on surgery. One of the most important things that I always take into consideration, the first and foremost thing, is that drawing a horizontal line in a rest position, that is, clinical backward horizontal plane is drawn, and through the subnasal and perpendicular line is drawn. This line is expected to go to the upper vertebral border, and about 2 millimeters behind, 2 millimeters anterior to the lower vertebral border, and about 4 millimeters anterior to the bone. So what this indicates is that if this position is anterior, then plus or minus 2 is always considered within the normal limits. And then if it is much more anterior, then it's going to have anterior excess of the maxilla. And here also whether the dento-alveolar segment, and here they will say that it is a chip, and both together it is a mandible. So it is comparatively easy to understand what the situation is. So it is comparatively easy for you to decide what surgery is. This is a proportion of one case which I have just shown you. This is the clinical prime for horizontal plane, and this is the subnasal perpendicular, nasolabial angle, and you can see that lip is completely forward, and this is more than this. So this particular region is more than this because of the lip incontinence and visibility of the teeth in the pose. So this particular patient definitely needs, from this alone, you can take a decision. There is a visibility lip position is not there. That means that there is a vertical axis of the maxilla and there is a vertical axis of the maxilla. What we have to do is that a default one osteotomy and superior position. So, and again, when the nasolabial angle is acute, we know that it is an anterior protrusion, EFT protrusion of the maxilla or the dental segment. So you have to do an anterior maxilla osteotomy. And of course, chin position is also far behind, so you have to do a genioplasty to bring it forward. So this is a very, very, when you draw this, to trick medium back becomes comparatively very easy. You are not looking basically into any of the supplementrics, or of course, X-rays can be used for the same thing, and that is actually better than a photograph in a way, and of course, you can plan the treatment comparatively easier because I will come to the classification a little later. So this is something which is important. Of course, those on the lines also you can draw so that you can find out the symmetry of the face. Another important thing that we have to consider is the labiomental fold. Labiomental fold gives a definition to the lower part of the face, that is the lower third of the face. It gives a definitive definition for the face, and it is somewhere around 4 millimeters, and this particular line is being drawn both the lip and the chin, and of course there is a aesthetic line also which you can draw, and well, I need not explain here what the aesthetic line. These are certain few clinical criteria which you have to take into consideration. But I am coming to a classification which is probably not the routine way that I follow, that not me, but in textbooks probably you may not get it. This is one which I stood for, which is comparatively easy. The skeletal deformities of the nose alone, I am not going to bring it. Most of the classification we see is craniofacial. I am taking it only for the maxillofacial region only, because we are doing basically orthognathic surgery in the middle third and lower third and not in the cranial region. So classification, this classification probably will be comparatively easier. That is maxillary protrusion, it could be skeletal or dento-alveolar. Maxillary protrusion could be skeletal or dento-alveolar. And then vertical deformity is again skeletal, excess is skeletal or dento-alveolar. When there is dento-alveolar on the low vertical excess, well, it is deep by 20% on the things. And deficiency, of course, and deficiency also could be skeletal or dento-alveolar. And if the dento-alveolar deficiency is there in the vertical direction, then you get a more white in that way. And maximally transfer the broad or narrow. When you come to the mandible, the same way it can be skeletal or dento-alveolar protrusion and transverse deformities. Maral deformity is something broad, narrow, prominent, deficient. Coming to the chin, it will be vertical, transverse, or anteroposterior, and chin deformity is deficient, vertical, transverse, or anteroposterior. So once we know this particular classification, it is comparatively easy for us to decide what treatment, what we have to do. Deep white deformity is again then upper white, facial asymmetry, etc. That completes it. I again go back to the classification once again. See, if there is, once we have got this particular clinical criteria and the occlusion And all these things we will be able to immediately classify into what extent, to which classification it belongs. Once we know that when there is a protrusion, if there is a skeletal protrusion only, what we need is only an anterior maxillary osteotomy for that. And even if it is a dendroalveolar, then I think that orthodontia is the right thing rather than going for the anterior maxillary osteotomy. And when protrusion, when it is skeletal, you may have to do a deformed osteotomy and advancement of the maxilla. In the dendroalveolar, probably it is the rare scene, or maybe can be managed by orthodontists. Vertical excess, vertical deformity in the skeleton, or even dendroalveolar probably to some extent orthodontically you may be able to correct, but when there is a vertical excess, it will be total maxillary excess or just the dendroalveolar is only the anterior. So an anterior maxillary osteotomy may be sufficient in this case, but when there is an excess, vertical maxillary excess in the skeleton, you have to do a default one and superior positioning of the maxilla. Deficient, when it is broad, of course you have to do surgery, mid-palatine split that expands it, or rapid expansions, or high-rise expansions, or something of the sort that we may have to do when it is standard. Even surgery and assisted surgery expansions can be done. But mandibular protrusion, skeletal, of course you have to do either a sagittal split or ramus osteotomy. There is a sagittal split osteotomy or a subsequent vertical osteotomy. All these are the two important procedures which is there, which can be done. If the dendroalveolar segment only, then maybe you can just manage with a lower anterior suborbital osteotomy. Protrusion again, basis of the bilateral sagittal split osteotomy is a versatile procedure, and so we may be able to do a sagittal split again and bring it forward. And transverse deformity is not an easy thing to correct, but to some extent, the midline osteotomy can correct a broad matter. Malar deformity, malar osteotomy has to be done accordingly. It is not a very common procedure, but I will see sometimes when there is a deficiency, sometimes a grafting will be better than making the osteotomy and bringing forward. Chin deformity, again, genioplasty, by cutting the chin, you can move it in almost all the three dimensions, and then you can take it upward, backward. So any deformity of the chin can be corrected by genioplasty, by which it can be moved in all the directions, and even facial asymmetry to a great extent can be corrected by genioplasty, which is something called extended smiling genioplasty, which can be extended. And almost it is the lower borderline for osteotomy, which completely extended genioplasty. You can just move it, slide it, rotate it as well. And to a great extent, facial asymmetry can be corrected. When I am going to pursue the facial asymmetry, I will show you some of the cases where a great deformity has been completely corrected by this extended genioplasty. Deep deformity, depending on the deep deformity you may have to, because it could be because the deep bite, especially the open bite deformity or orthognathic, it could be a deficiency of any part of the skeleton. And it could be a posterior deficiency or excess of the posterior maxillary segment, or deficiency of the anterior segment of the maxilla, or it could be mandibular segment. All these things can be there. So exactly analyze and find out with all these matters. You will be able to find out exactly, looking at nervosity and other clinical criteria, you will be able to find out exactly where exactly the deficiency or the problem excess lies, and accordingly you can treat. This is the envelope of discrepancy. This is something which has been already described by wealth and profit, and of course I have added one more line, because when wealth and profit proposed this discrepancy, there was no distraction. Distraction came only later, so we can distract the mandible, the maxilla over almost up to 25 millimeters. Probably I think that Manila is an expert in doing that. And of course, mandible can also get advanced to good extent by distraction, osteogenesis, which is probably one of the key things in orthognathic surgery right now. I wanted to tell you something about the illusion. Or we're looking at this, upward two horizontal lines. It may look like. Can anybody tell me what it looks like? Is it a parallel line? Is it a convex or concave? It looks concave, isn't it, to the upper one, and the convex and the lower one appears to be concave. It's mainly because the other lines, that vertical lines, activated lines are put in such a way so that you feel it is both are parallel lines actually. So this is what I'm going to tell you, this illusion. This illusion is there to the face muscle. So it is not the linear measurements of the angulations alone that take the beauty of the face. It is basically the proportion. You are not going to look at the nose alone, or the lips alone, or the cheek alone, or the chin alone. You are going to look at the face in total. So the proportion between nose, chin, cheek, nose, etc. And when you smile, the position of the lip, these are all in total we take into consideration. So many of the cytometric analysis you get the linear measurements and of course certain angulations. But if you are just going to take and depend completely on the linear measurements and trying to correct that psychologically correct facial base, then you are going to be in trouble. So I tell you, the proportion is more important than the linear measurements or angulations. The clinical features of maxillary, vertical axis of the lower face, visibility upper teeth by more than 2 to 3 millimeter, dummy smile, difficulty in opposing the different tooth, nasolabial angle, convex facial profile, upper lip more than 2 millimeter, and the object and these are certain clinical features of maxillary axis. And several findings, well, that is not my topic, but anyway, these are what I usually take the lesson, not all cytometrics analysis, SNA, that is good enough. And maxillary deficiency, of course, concave facial profile, nasolabial angle, reduced vertical dimension of lower third of the face, dishing of the upper third of the face, prominent lower lip, and narrow upper arms. Trapezial perpendicular FS plane is anterior to the perpendicular lower border. These are certain clinical criteria that see maxillary deficiency. And then mandibular access, of course, prognathosum, asks the relationship of the teeth, anterior close front, elongated face, and lower third of the face is relatively long, and stonial to mentron bend is proportionately long. Face appears concave, lower lip and chin are much anteriorly placed than normal. Lastly, relationship of inclusion. These are the things that we see in mandibular access. And of course, this is one X-ray that deficiency, mostly seen in necrosis or deficient growth of mandible, red face, severe ornament, last two relationship, crowding of the lower teeth, rare compensation of the lower anterior teeth, base appears small, lower of the face is short, stonial, disproportionately short, and tibial report is usually absent, chin, neck, ankle, scoliosis. This is the report, what posterior. See, in vertical axis of the maxilla, what you have to do is the report posterior. This is just I wish to show you the report. This is the paradigm on this. This is the anterior maxillary posterior. One. Sagittal speech. Lower subapical posterior. Usually done at the first premolar level, because if you go to second premolar, it is a member parameter, so you may find it a little difficult as exams may have to probably take care of that. And this is genioplasty. This is the case where I have done the lower subapical and the genioplasty also as well. So this tooth of bone is maintained there so that this is what is called the extended lateral spinal genioplasty. When the patient is symmetry is there, you can just cut off the mandible or below the mandible cut and then slide it so that the deficiency here is filled up and the deficiency of the entire mantle can be brought forward and it is slided and stepped and if one can be a graft. So this is the case where it is sliding. So this area, one side of the mantle can be, of course, Mylar deficiency and Cruiser syndrome. Often right is another, in this case, see, in this can be analyzed, in whether the position, consider the position of the lip, you can find out, see, the canine is up to here, only the anteriors are the, so it is a deficiency of the, either, it is a vertical, and this is competence is also, there is a vertical excess of the maxilla in the posterior. So you can do a report one. And an external maximum posterior and excessive reduction and unfortunately you will reduce the posterior radius of the maxilla and then take it upward. So the open right gets it up. Facial symmetry, of course, common reasons can be explained for the patients, so we are not going into the details of that. So that's our and possibilities and limitations. Maxilla, it's not easy for the maxilla to be pushed backwards because there is a restriction to the pterygoid junction. But if you are going to osteotomize that pterygoid plate, then maybe you will be able to push back towards a little extent. Or if you are going to do the osteotomy of the deep tweeting also, then you will push back. Otherwise, maxillar pushback is comparatively easy, but it can be brought forward, bringing it forward, the tissues will hold it back to the brain. And the lapse rate is comparatively high. So that is one disadvantage, one problem with the advancement of the maxilla. But if you are using the weights, weighted screws, or you will be able to, again in the mandibular, VSSO is a versatile procedure where you can take the mandible backward, forward, rotate it, or even slide it to some of the other. This is something I will show you some of the cases. This is see how that some may say perpendicular or by plant. So clinical criteria only active in preservation. So the lip is forward displayed so that I consider the scientific maximum excess. There is lip incompetence and dummy smile. So I think this is a vertical excess of the maxilla and chin is deficient. So naturally what I have done is that I report what anterior maximum osteotomy and anterior-plasty. That is being done, and this is what we are talking. So, just for the clinical criteria itself, you will be able to make research what exactly is done for the patient. This is also again almost the same temperature. You see, there is a vertical excess of the maxilla because of the visibility of the teeth is there. So, this is the appearance post-operatively here before, and this is see, in many of the cases where there is a vertical excess in the maxilla or bimaximal protrusion, the lower teeth also, there will not be normal teeth. It will be normal. It's only vertical excess. So in such cases, you can do a remote one anterior maximal osteotomy, and if the chin is also deficient, you cannot do a lower subapical. So the chin still remains deficient. So a resurgical orthodontics in such cases, of course, as it is a teamwork, resurgical orthodontics is basically for your eye, but in these situations, you can create a normal tooth by just extracting the premolars and then protruding the mandible, the lower anteriors and low. Once you do that, the orbit will be increased up to 5 to 6 millimeters. If you are going to get about 5 to 6 millimeter orbit, then you can really report one with an anterior maximal osteotomy and genioplasty also. Because it is not easy to do a lower subapical, anterior subapical osteotomy and genioplasty together, because it is almost the same place you are going to go, especially when there is not much vertical. A little off track, instead of I have taken the entire prolate and reconstructed the nose, and then there is no feature. So what I have done, I did share away flat and reconstruct the have it leach. Yeah, this is probably the last same patient. Then coming to the mandibular orgasm, it is in this case it is a lot of my old cases, one of my first cases, 1982 or 83, 84 I got this case. And at that time I was only confident to do it by that scientist, those circles I did a subsequent work to those circles. You can see a small scar there, but this is a SAX case, and well, look at his chin, it is comparatively deficient, and he has got a fast root. So the entire mandible is protrude. This is a situation for genius deficient. So when I did the report one and take this, I mean scientifically took the mandible backward in the class 1 relationship. This gene was deficient, so I had to do a genioplasty to bring it forward. And double chin. That was it was very deficient chin, so single genioplasty was not sufficient, so double sliding genioplasty has been done. This is a case of ankylosing spondylitis where there was a definitely deficiency in the upper. She has a correct functional correction has been done. She has some rock in the mouth, but somebody has tried distraction, but it failed actually. So I did an external map of finding genioplasty of her, and thank you very much.
So just before we get everything right up here, this is going to be a surgical session, so not much of a role for orthognathic. But I think by saying so, doesn't mean that just wanted to, it's a little different topic from what already been discussed here. I think initially the face conference was mainly meant for orthognathic surgery, but then now there's a lot more interest in orthognathic dance as well as in distraction motion disease. So when I was discussing with Dash and I said, I'd preferably like to do what I'm doing more, in the recent years. And do you mind if I just talk about two more topics on something else other than just routine orthodontic surgery? So let me talk about that. One of the topics which I probably found maybe different from orthodontic surgery is that, what exactly happens in mandibular extraction post-genesis. So, to be very frank, our center in Chennai, we were very lucky that in a center which gathered all the group of patients, including congenital versus the magnetic maxillofacial and orthodontic, all forms of patients. And from 2003, we have a center which is funded by Switzerland International, and we operate about 600 to 700 clinical pilot cases every year. And sometimes there goes up to 800 as well, depending upon the number of patients we operate. And every day at least 3 That's the time we were probably from 2000 when I came from Ukraine. Before my Paulson and Robert, my teachers, and they all taught us how to do really the orthognathic part of it. But when it comes to the congenital, certain congenital disorders, we have a lot of limitations. So when I say limitations, the limitations in the form of how far we can really do orthognathic surgery in a child with a severe congenital deformity. How far you can really do, how extent you can really perform these things from a small baby from the age of 3 months to the any age what you want to do. So there are a lot of learning that we had, like the failures, the relapse, and so on things. So then in 2003, we were very fortunate to have training in distraction disease. And from there we started from a very simple form of distraction. We went into now we do starting from sort of a simple maxillary unidirectional. We go 3 levels of distraction and quite an array of things we do it. But just to give you a little idea about the mandibular distraction alone, I'm going to talk about today. And in the mandibular distraction, there are so many areas where you can do the division. Okay? Now, sometimes many of them you saw the previous pictures in orthognathic surgery. You can do really sometimes simple orthognathic surgery for a deformity like that. You can correct the orthognathic surgery. But then distraction, you can apply certain post-traumatic cases including TMJ problems, micrognathia, and of course non-symptomatic. Severe micrognathia non-symptomatic is one of the indications. And exclusive condylar distraction. We are also doing a lot of that condylar. I'm not talking much about it today. Alveolar distraction, the post-tumor excision, transverse skin distraction. Of course, the recent one is the obstructive sleep apnea, a lot of concentration on that and so on. And in syndromic, of course, if you see, periodontal, fracture cranial Microsoft stickler syndrome, and golden syndrome. All these cases you can do distractions. Now, as I told you, everything was a learning phase for all of us, and we also had a similar sort of feeling where we learned from a simple distractions to the most complicated. It was not easy. It was not like 50 years of orthognathic surgery. You learn from somebody who was actually really taught and experienced, and we had the result. It's not like that. Of course, we did orthognathic surgery like that. But then with the distraction, it was new for us for the last 10 years, and further it was quite a long journey. And we ended up in something like that. Patients, so different patients, you can have a very 6-month-old baby like that. I'll just show you a couple of cases just to show you, from this age to any age, you can have a walkover distraction. I will come into that little by little. Normally with our center, when we see a patient with we think that congenital deformity or what we can do it. Like any other clinical examination, the position of the sleeping position, specifically the obstructive sleep apnea, you have to know from the patients, from the parents, that how the patients sleep, whether the side or normally supine position, good radial arc and the CT scans. And of course, when you have an obstructive sleep apnea problem, you have the poly as well. I just put this because a general thing, whenever we talk in terms of distraction, we should not forget the Russian who actually dedicated a lot of his orthopedic time in lengthening the limb action, and which was started with that, and later of course was taken up by different maxillofacial and craniofacial fraternity from US and Europe, and they ended up in developing something called the maxillofacial starting from 1983 onwards. So we are hardly 30 years now. The maxillofacial distraction is hardly 30 years now. From there, starting from the technique to the instrument and everything, there's a long way they have to come forward. And I was fortunate 10 years ago to meet Professor Sailer, as I already told you. He is a man with a lot of distraction from that time. Of course, it does some of the distraction now
and the University Hospital and Clinic for Inflammation is considered the mecca for, all the invention of craniofacial surgeries all over the world, including Paul Kessler and, the Orthognathic all these gentlemen actually was trained. He's number 3rd in the line after Dr. Orthognathic Dr. Seiler. He's a very good humanitarian now, and he has about more than 5 or 6 centers of clinical and craniofacial supported centers in India, mainly in the south of India, but I think we have some plans to come, sort of now we are looking into centers to expand more and more. And 10 years ago when I visited him, you can see the amount of physiotherapy model behind him, the amount of craniofacial surgery which he has done. Of course, not everything is a distraction, many with other things. And from there, I have taken the little bit of a clue how to do the distraction and everything. Just to put it a little bit for the concept point of view, you can tension the mandible in one direction, or you can, the vertical or horizontal or whatever. And of course, the 3-dimensional, what is called as the transport distraction. I do not do much transport distraction personally, but outside that process of dealing and there's a lot of transport distraction. Of course, he has done quite a bit of number and I do more in terms of related with craniofacial course, because that is my interest and passion to distraction and craniofacial. This baby was brought to me when the baby was hardly 15 years old, and you can see here there is a severe recourse curve and the pudding, and you can see the tracheal area, how much the tracheal does because of the difficulty in breathing. The problem is, of course, the failure of the sequence. We get a lot of these children with severe mandibular orthognathism. Now, to be very frank, really the treatment aspect, if you see, if you have left palate associated with the microgenia like that, you have so many options. With the CT scan for a baby, you see that how badly the mandible and the airway can be compromised. We did a lot of 3D-dimensional studies to see how badly and how narrow this can be, and how many, sometimes hardly a millimeter or 2 millimeter of airway you see, which can get blocked any time and making it difficult for the baby to probably to survive even. And the same way you can see that how emaciated because of the nutritional problems, difficulty in breathing, and you can see the blood pressure. So this was something which prompted us to do a lot of treatment in this type of patient. Now in PRS, in periodic sequence, you have of course so many type of treatment options which is available. Treatment is purely based on center to center. There is nobody like definitely okay, I have a better result in the city center to center. And I just wanted to put it, but just to say that please do not carry behind and think that periodic sequence, if you have a mandibular deficiency, distraction is the only thing. It is not like that, because many of them do try tongue leaf hydration, and a lot of them do distraction with tracheostomy, and some people do a conservative treatment, just wait and see. Some of them just keep intubating and wait and see what happens. But everything has a role in itself, and I think recently there is a lot of interest in taking momentum in the distraction osteogenesis for the periodic sequence. Now, what is the advantage of this is that, before that I want to just show you here is that if anybody has not seen it, just for the introduction, this is what we call for the periodic syndrome, the tongue having suture on the lip completely. This is the first line of treatment we need to do it. Because once the tongue is being pulled forward and sutured on the lip, the obstruction is being removed to more or less. So this is one way of a soft tissue correction to correct the airway of the patient. Many centers still do it. Very good procedure, extremely helpful for the child initially. For a couple of days, you have to feed the patient on that nasogastric tube, probably for a week or so, because it's very difficult to swallow without the tongue functioning or moving properly. But then, if it functions very well, it produces a very good result. You can see the same baby after the tongue leaf operation. In a year of time, he was like this, chugging, eating very well, absolutely no problem. breathing area. So this is what probably a common belief addition can make. But now if you look at him from a lateral perspective, what have not able to issues work? So now the question is whether we want to still do something or not. I have done it particularly in this case, the parents keep on complaining. He has a severe snoring and we are so worried about it. So can you do anything with the mandible? So this is what I was trying to tell you. Please remember that when it comes to orthognathic surgery, we have some limitations. We cannot perform that in the children specifically because we have fear of having the growth problems, the teeth problems, whether how they will grow. If you do a child, sort of a mandibular like a student, how they will grow. So many types of questions which are not answered. That is why in pediatric group, specifically the congenital deformities, the distraction still is considered to be a temporary option. You can see the same maybe we try to do a distraction and this is a unilateral distraction. What we have done is only lengthening. We did an extra one offering. Then there is an internal distractor and marked internal distractor. And we have, you can immediately, during surgery itself, we try to move it and see whether the mandible is really moving or what can move it. And it has been proved beyond doubt now that, in the table itself, you can move up to 5 millimeters and leave it. And so that produces a tremendous amount of relief for the baby to start breathing again. The obstruction is completely removed. And please remember, in PRS, you can do a distraction the next day after the delivery. You don't have to wait for months or days or anything. If somebody is able to keep the baby good, if you have a material in the hand, day 1, next day you can do a distraction, relieve the airway, and the face will be normal. So just to show you that this is what after you can see that they know what has happened in this baby. So this is what we are trying to achieve. It is only with lip adhesion, as I have already told you. The patient is very good. No complaint apart from the fact is that the mandibular bone is affected and has got a severe problem with the skin technique. So this type of the cases we have done, the discussion for the mandible to keep the function going. If this baby is continuing to grow, for example, at the age of 5 or 10 or 15, you may encounter the same baby with a severe recurrence. And for 18 years, you are waiting for an osteotomy. Please remember, the patient has an osteotomy, we keep on continuing. And if we can distract in between, it may be that, that we are giving a stimulus for the mandible to grow. And in our series, we have a couple of group of patients now we are studying for last 10 years. After distraction, how is the mandible is really growing? And we have some proof now that, the mandible actually can grow to a certain extent. It may not be to the extent that a normal mandible grows, but 80% of the growth is picked up by the mandible if we can do a distraction much earlier than what is typically related. So I think it is very important to understand that distraction play a bigger role in children as well. This is another periodic syndrome with vertical paralytic epilepsy, how difficult for a child sometimes. It is not only difficult because, if you want to do multiple surgeries in this patient, it is not easy for the anesthetist to keep on intubating on a child with this obstructive problem. And it is always very difficult. So in such cases, you can see here again, the mandibular distraction with the other one was actually from the anterior distraction point down here, you can see here, the distraction bone goes from behind and we try to push the mandible forward by using this internal and there is a same. So they produce quite a bit of tremendous result. There's another thing here again. I don't want to show you, just want to tell you that there are certain indications exclusive in the childhood for babies, and this is probably one of them. And another one, of course, is the 3-year-old patient again. This patient is, I saw about 10 years ago. I still have that patient in my review system. We keep doing that. Patient was 3 to 4 years old, severe culture point syndrome with mallar deficiency and open bite and mandibular problem. Same issues. The difficulty in breathing, the difficulty in growth of the mandible, and waiting for 18 years or 17 years without doing anything cannot be a cancer. for the surgeons. So I think this is one occasion probably, or an indication probably one can look into a distractor like this, you can put it internally, but then the activator comes outside, and that is what you can do in our hospital. Just go back and see that the amount of lengthening of the lance happens there. You can see that. You can go as many as possible. So with the osteotomy, probably you might have a limitation to structure 10 minutes. So this is one case you can see that we have done a distraction with the right side, the facial microsomia, an external device was placed and used. And you can see here, also, I think this is technically the ankylosis, if I remember very well. But then, in most of the cases, if you see here, this is quite not what we call here, probably. You still get a lot of ankylosis cases here. And I don't say that we don't get it, but the amount of incidence of ankylosis reporting to the centers in South of India has really become now much comparatively lesser than what it used to be. I don't know what's the reason, maybe because the stock or whatever it is. But yeah, it is much less now here. But whatever we have done a study for last 6 to 7 years, even if you have a problem with ankylosis, we used to do the distraction before we release the ankylosis. This for the last 10 years we are doing this type of distraction. That is distraction before the ankylosis release. And the advantage we found that we can make the mandible move in all directions, whatever you want it, correct the obstruction, then you try to correct this, ankylosis. We have no problem with it, absolutely no issues, no problem with occlusion, no problem with the difficulties. So it helps the anesthetist a lot as well afterwards because any procedure we do after the distraction, it makes it easy for the intubation and so many other things and the growth. So we just to show you that that mandibular lengthening what was achieved in the same way. The same way we used to get a lot of syndromes with missing ears and use of mandibular electricity. Again, any mandibular problems, we used to do a lot of monofocal and bifocal distractions. So you can start from distraction advantages I told you. You can start from any age. Now it's the same maybe now recently about a couple of I think 1 or 2 years ago. We still keep coming to us, we keep following them. Another medication one with lip and pattern involved along with it. In other words, they want to correct only the basal bone here without touching any of their occlusal aspect completely. And we did a separate osteotomy here like this. I have a separate presentation for it, but I'm not ready to put it here today because the time is a big factor. So this goes from one side genioplasty, this is done on the normal side, goes to the other side, the body is the rams, and goes completely on one side. And with the distinction, you can probably achieve, this is what the big achieve like that. And you can see the amount of achievement with the distraction, what you see here. The chin point, what is achieved here, the chin program. This is tremendously improves the appearance. You can see here from that to that, the lower part of the mandible becomes almost normal. The lower part of the mandible. This part of the mandible has been completely moved to one side, and this is another patient which was done with a similar technique, orthognathic distraction. This is the complete basal bone. This patient had ankylosis, released, then corrected only the basal bone. This patient does not have any E41, no other osteotomy, and only occlusal arrangement and an orthognathic osteotomy. And that is what we are doing. So the basal bone moves completely to one side. And probably one of the best results we had is that, when you have a patient like that, when the patient is not interested in going for a long-term orthodontic treatment, is not ready for a E41 sagittal split osteotomy, genioplasty, the multiple osteotomy procedure, still you not get what in a 3-dimensional body model. And this orthognathic osteotomy, what we are showing here, along with little lengthening of the mandible, can produce some tremendous results along with it. All this treatment cost a lot of money, specifically when you are using a marketing distractor. Each one costs nothing less than 1.5 lakhs nowadays. Okay? And some Indian distractors are also available nowadays, very good ones. But I think what learn, experience yourself. And it takes a long time. To be very frank with you, our journey started 10 years ago. It was not easy for us to, it is not one case which is going to have change your perception about distraction. We have used now distraction exclusively for certain indications. Not everything outside our front of the face is not really using. In comparison to the posterior, please remember, you cannot take the matter backward with it. It's only an advancement possible with the distraction and the quickest disorder is still with the distraction. Please remember that. And I would like to thank our sponsors, Society and Dr. Rita from Switzerland. They have so far, to India, if I remember very well, the last census is that they have donated money for taking about nearly about 40,000 patients. And they receive a single handed trust in Switzerland. It's an extremely good humanitarian, one of the fantastic European radiation surgery I've seen, who comes every year to here, teaches us something new and different about the animals. And because of him, that we have learned a lot, did a lot, how children got benefited a lot from that. And that's my surgical team from Meenakshi, Dr. Anand, Naveen, and Sneha. So we have a big team of people. We try to do what is best we can do it with correct protocols and hopefully 10 years of time. I don't say 1 year or 2 years. 10 years of time. We wanted to really make it. It is probably one of the centers, but probably now we have actually trainees do come from a lot of African countries. We have one trainee from Germany. So now we are trying to attract people from outside the world to India, where we used to go from there to there. Now we want to bring them back here. So that we have the capacity, we have the skill, we have a number of patients as well, of course, so we can really make centers of excellence by our hard work. Thank you.
About the surgery first, it's a concept that's very new and it draws a lot of attention. I'm speaking on an orthodontic perspective. The idea behind this presentation is to introduce the concept and then take the evaluation. As we know, we live in a patient-centered society. The treatment of malabsorption and skeletal discrepancies require both orthognathic surgery and orthodontic treatment. The orthognathic surgery was done to address skeletal discrepancies and improve the profile, where orthodontics was more focused towards occlusion. Now, surgical orthodontic patients usually express high levels of satisfaction provided everything goes well. In a study done by on 139 patients, 92% would recommend that to a friend and have the operation again, and up to 99% report an improvement in appearance, function, and both. Now, surgical orthodontic treatment traditionally involved pre-surgical orthodontics like decompensation, arch coordination, followed by orthognathic surgery, and then post-surgical orthodontics. The conventional approach is what we showed you in the morning. Orthognathic treatment proceeds and prepares the dentition for orthognathic surgery to correct the skeletal dental discrepancy. Now, teeth naturally compensate in an effort to mask the skeletal discrepancy and establish the best occlusion. These are compensated cases. So, this is what we do. We decompensate a proclivity bring them into IT utilization and then perform the surgery. This is how traditionally most approaches are done till today. So, suppose you had severe proclivity, we would extract them in a particular fashion, create the object, and then do the surgery. Classically, cases you have flared upper and lower incisors. So what we used to do is again do extraction and then followed by surgery. The extraction pattern would be usually upper first premolars, the reverse of class, that's upper first premolars and lower second premolars to create a reverse object. One problem with all this traditional approach was what they felt why this concept actually came about is there used to be a disfiguring of the face further because you would do reverse orthodontics, the profile would become worse, and a lot of patients had a lot of problem with this. And then they would finish the case. The length of the time for decompensation would be very, very long. So that's what got surgery versus orthognathic approach into prominence. Bell and French said that it was a paradigm shift in orthognathic surgery. Eric Liu, in his article published, mentioned that the treatment duration was shorter by a year and a half, and called the approach surgery first accelerated orthodontic surgery. But actually, is this concept new? The question is this concept new? Well, in my research, what I felt was in 1947, when orthodontics was not at this highest level, this technique was done and they used gold plates for fixation. So actually, we are looking at the thing of the past resurfaced again. So in surgery first approach, orthognathic surgery is performed first, then followed by orthodontic treatment. The surgery first approach treats facial aesthetics first and then occlusion, whereas in the traditional conventional approach, the occlusion is treated first, followed by facial aesthetics. The surgery first approach is to proceed with orthodontic surgery in the beginning without any pre-surgical orthodontics, and most of the orthodontic treatment is done after surgery. So surgery first approach uses osteotomy to solve the skeletal problems, and a transitional occlusion is set up after surgery. When I say transition, it means temporary occlusion, that's not the final occlusion. See, orthodontics in surgery first approach is a post-operative adjunctive treatment to change the transitional occlusion into a stable cusp of post-occlusion. That is, from a transitional occlusion, what is achieved after surgery to make it into a stable one. So, what are the advantages of the surgery first was reduction in treatment time, as I mentioned. No disfiguring, no decompensation where the patient has to go to a further worsening of the profile. It increases facial aesthetics straight away. And there's no progressive deterioration of dental function. The advantages of surgery first approach can be divided into psychological and biological. The psychological approach is usually in traditional methodology, pre-surgical orthodontics is very lengthy. So there's worsening of the profile, and this makes the patient very unhappy. The other advantage is that there is immediate gratification because of improvement in facial aesthetics, and the patient has no attention regarding the profile, so better compliance post-surgery. So, to put it in a nutshell, the patient's chief complaint is addressed at the beginning of the treatment. So that's the big psychological advantage. Now, when it comes to biological advantage, in pre-surgical orthodontics, a space closure or extraction space is created as completed. Once the space closure is completed, then it is subjected to surgery. Whereas the surgery first extraction can be done after surgery, space closure to achieve class 1 ideal oversight and oversight can be carried out with precision. Now, the total duration of treatment time, as I mentioned, is reduced. This can be attributed to two factors. One is the role of soft tissues, as Dr. David in the first presentation today showed how the soft tissue changes, and regional accelerated phenomena, also called as RAP. Now, the role of soft tissues, particularly in class 3 cases, because the class 3 malocclusion is made into is brought into a class 2 relationship, it results in an improvement in the tone of the upper lip, and the tongue increases the force on the insides of both arches, improving the efficiency of incisor decomposition. This phenomenon may also be a factor in reducing total treatment time. So this is what, to put it in a more diagrammatic or futuristic thing, is this. The class 3 case is brought from class 2 and then brought forward. So the other factor attributed, which they claim is the most important thing, is the faster tooth movement based on the regional accelerated phenomenon, also called as RAP. Now, what is RAP? Well, it was discovered by Harold Krosnow, pedist in 1983. He said that the bone turnover adjacent to the site of surgical trauma is increased. Wilcodontics, as it is actually primarily a Rico and his colleagues have reported that corticotomy can enhance tooth movement by increasing the bone turnover and reducing bone density. Similarly, the bone turnover after orthognathic surgery can significantly accelerate tooth movement and reduce the overall treatment time. So the orthodontic tooth movement is usually 3 to 4 times faster. There's increased bone turnover and decreased bone density. Now, proponents of this particular approach, that surgery first approach, says similar bone turnover after orthognathic surgery significantly increases the orthodontic tooth movement. So this is the basis of this whole concept. Now the counterpoint of this was rat phenomena is a site-specific. Bone turnover is usually increased in the site immediately next to surgical trauma. So how can there be an increased tooth movement from anteriors when there is no surgical cuts over there? Till today, no clinical trial has shown a comparative rate of tooth movement of surgery-first approach versus conventional approach. So people who didn't believe this had these things favoring them. Now, in a recent article in 2011 in a MaxPack journal, Eric Yu mentioned that the ALP and CLP candidate markers for tooth movement increased level was seen post-surgically, indicative of increased osteoclastic activity, and tooth mobility did not increase for the incisors. Now, which are the best cases for surgery first orthodontics? Cases indicated are the ones that do not require too much of pre-surgical orthodontic alignment and decomposition. A well-aligned to mildly crowded anterior. So flat peroxide and normally or mildly proclined or reclined incisor inclination. These are the best cases. So in preparing the case, you need to have the following step. You need to have a pre-surgical evaluation, a soft tissue treatment objective, surgical treatment objectives, a modern surgery, full mouth bonding and banding, orthodontic archwire may or may not be placed before surgery. So this is basically how you prepare a case. Now, the orthodontic archwires, some of them who don't advocate placing earlier are placed after surgery for alignment. The jaw bones are hence having a rigid fixation and tooth extraction might be indicating severe cases. So surgery first approach is also indicated in cases where decompensation is needed. What I spoke about was the best indication was cases which don't require, but they can also be done in cases which require traditional decompensation. Now, how to position the jaws properly without compromising surgical results in such cases? That is, cases which require to be decompensated. Now, surgical treatment, surgery first was possible with two concepts in surgical techniques. One was rotation of the maxillomandibular complex and segmentation of the maxilla. So this is a basic diagram of maxillomandibular rotation of the complex. So you connect the ANS and PNS and the overhead and you use the fulcrum either at the upper incisors or at the ANS and try to simulate movements. So this is a patient which had a severe pharyngeal deformity, and you see here a combination of both maxilla and mandibular cord, and the surgery was done accordingly. And the other segment was segmentalization of maxilla. The coming to cases, like I said, that the best cases for surgeries are can surgery first approach be used in all cases? It should be used with caution when there is severe dental decomposition, severe crowding may not be the right case. It is possible in class 3 cases, but is it as effective as in class 2 cases is the question to be answered. Now, the success of the surgery first approach is evaluation of the true skeletal discrepancy and a surgical treatment objective has to be established. Both the surgeon and the orthodontist must be very clear of the final goal. The skill of the surgeon and the skill of the orthodontist are the two most important things. The surgeon should know what he's doing and the skill of the orthodontist to know where he's ending. It's totally important. So in conclusion, what I would say is to weigh and consider might not be foolproof because a lot of studies have to see whether these results are stable. With this